One, check. Hey, hey. One, check. Hey.
Is this...
Guys, can we all just settle down, please? We're just going to start. So apologies for the delay. Over to you, Pragya. It's the start.
Oh, sure. Is this taken?
Welcome everyone, and thank you so much for joining us today for this sector workshop. We'll request everybody to settle down. We're starting now. All right, thank you everyone for being here and for your patience over the last 20-25 minutes since we've been struggling with some technical issues. I'm Pragya. I am part of India Blended Finance Collaborative Initiative at the Impact Investor Council. And what we do at IBFC is basically two things. We are here to build awareness, and two, to deepen engagement in the blended finance space. What that means is we bring together both private capital investors, philanthropic investors, as well as different sector experts to come join us, share their experience, insights, as well as opportunities in the sector. So welcome everyone. Before I hand over to Ramraj, I'd just like to maybe go quickly over the agenda, which some of you would have already had an access to. So we're starting off, obviously, with the initial introductions from the IIC team. After that, we have a session on using blended finance to drive impact at scale, which is being led by the USAID team here. We have Gautam and Apurv here from the USAID team, and also Neeta Rao, who will be joining us virtually. After that, we will be moving on to a deeper discussion on opportunities, specifically in the healthcare space, challenges, as well as some of the key priorities and subsectors that the team will be sharing. We have both the SAMRIDH and the IPA team, as well as Cois Capital here, being represented and sharing their experience, which we hope you'll find useful. Now, just one point here is that obviously we are here to share, the speakers are here to share what they have learned, but we are also looking forward to learn from the audience as well. So please do feel free to participate as well as ask questions. While we have some specific slots for the discussion and Q&A, we hope you will also engage in the conversation as we go through it. So after that, we break for a small tea, coffee break, and then moving on to some practical case studies, as well as learnings on actual transactions that both the SAMRIDH team as well as Cois team will be sharing. Post that, we do have another half-an-hour slot. We have three esteemed speakers. We have GSW Foundation, ACT Grants, and Waterfield Advisors, who will be joining us to share their experiences and what they understand about the blended finance space and how they think philanthropic investors can participate more. I'll now hand over to Ramraj, CEO at IIC, to share his thoughts and to kick this conversation. Thank you again, everybody here.
Yeah. Thank you, Pragya. Can you just raise the volume, please? Volume thoda badha denge. Yeah. So thank you, everyone. I think as Pragya has spoken, I think, the Blended Finance Collaborative is something that we started last July. Lots of you, who are here in the room were also part of those initial conversations. The whole agenda, as I think Pragya has underscored, I don't want to speak too much, is really to expand the scope and scale of blended finance in India. We've had till now about 4 sessions. Much of those were master classes, which were focused around creating capacity, helping a larger base of people to understand blended finance. So essentially kind of creating a larger, if I may say, pipe of people who are looking to do. We are now moving into a slightly more, what I'd like to say, the business end of the Blended Finance Collaborative as we have begun. This is the first of our sort of sector workshops. We are later this month doing a session around legal issues and how we could structure stuff to enable some of the kind of transactions to go through within the existing legal frameworks. So that's where we stand. In general, I think the response has been quite positive. We've been getting good response from for all the master classes. We've got a good response for all of you here. As I'm sure you can see, this is also a hybrid session. So we have a series of people also online who are participating in this conversation along with us. So, quickly on really, the whole idea of the workshop here is really to look at how blended finance can be used in health. Lots of you are here in the industry as practitioners. So I think the whole idea is to make this a lot more practical. We don't want here to discuss very high-level conceptual ideas around how, blended finance can be used, but really create this as a platform for various people who are interested more in the health sector and participate. Whether it is hopefully blended finance is something that we can work out. And why these kind of workshops are important is because hopefully in March we are going to start something called the Deal Spotlight Series, where a variety of people, and that's something that we have observed, a variety of people across the country are doing various blended finance transactions in bits and pieces. But there is no one platform where all of these people come together, share that they are doing something like this, because there could be other people in the audience who are maybe interested, but there is no way on earth that all of them know that something like this is either cooking or someone's fundraising, because this market is just developing. So who's interested in what? Really it's very, very opaque, not because of anything. It's just a market issue that there isn't a large enough base, or there isn't enough paper that is available around who's doing what. So we are hoping that these workshops, we are doing one on health, next will be agriculture, financial inclusion, climate solution, and usage of blended finance. This will be followed by the Deal Spotlight Series. We are hoping that various people will come with a variety of deals that they will talk about. And these could be a variety of deals. I mean, these could be senior subordinate structures, these could be catalytic TA, there could be a whole host of alternatives that we could consider. Idea is not to sell the transaction. Idea is to create a space that people interested in health could evaluate whether this is something that they are interested in. People interested in agriculture can evaluate whether this is something they are interested in. Whether they want to participate or not is a secondary question, which has many, many more steps. That's the larger context of this workshop. We want this to be interactive. We want this to be an engaging conversation. We just don't want that IP Global and COIS here presents their perspectives and then we really don't take this anywhere. Idea will be to keep this as engaging and interactive as possibly we can. With those I'd like to say a few words, but I don't think there were a few. There were quite a number of words. I'm going to hand over again to Pragya to take it forward.
Sure. I'll welcome Apurv as well as Gautam, who are here, and Neeta as well to now go ahead.
Hi everyone. Thanks so much, Ramraj, for those opening remarks and really for bringing us all together. When we started the journey on India Blended Finance Collaborative, the idea was to, spark some of these conversations around, what are some of the things we need to solve and how blended finance can play a role in solving, and really bring more players into this market and also deepen participation of the existing players in the market. Today, I'm going to talk a little more high level, and I'll pass it on to my colleague Gautam, who can talk specifically about health. But essentially, I wanted to zoom out, talk about why we are doing this. What is the eventual goal that we want to get at by these conversations, and eventually doing more transactions in the space. What are some of the challenges we need to solve? And then what are some of the potential set of interventions, blended finance or not, that are needed to sort of solve these challenges. And I think the message I want to leave the room here and rest of the folks there is there's really a need to take a very focused, sectoral and collaborated approach to really move the needle. Doing things sporadically, one-off transactions are not really going to move things significantly in the sector. So I'll start with the why, and I think I'd be preaching to the choir here because everyone knows these numbers, sees these numbers every day, remembers them in their sleep. But essentially there's a huge financing gap for what we are all trying to achieve, which is sustainable development goals or development goals, and public and philanthropic capital or public and development assistance, public capital and development assistance are not going to be enough. We need to find ways to increase private sector investment and private sector engagement in development, and that's what broadly we want to do. Next slide. So why is that not happening enough? Why is that not happening at scale enough in especially sectors that are slightly softer like healthcare, wash, agriculture, and others? There are various challenges which I'll not get into in the detail of right now, but essentially lots of different pieces that need to be solved to bring in private sector in a big way. And I think that's where donors, that's where implementers, enterprises can really come together and collaborate to bring about that change. And I think blended finance is just one tool in that whole puzzle that, is just one piece of that whole puzzle to solve all these challenges. Next slide. Yeah, so I'll just leave the room with different aspects that we think and that we think are needed to sort of bring together in order to really increase private sector investment engagement in all the sectors that we work in, and Gautam can touch upon health specifically. I think blended finance is just part of the solution. We've seen all these approaches when done in a focused way, in a collaborated, really can move the. We saw that in the microfinance industry. We've done a lot of work in the healthcare space already, or using all these approaches. We've done a lot of work in the climate space. So one is, supporting, using grants, which, most of us here do anyway, to support research and innovation. Doing that, putting that high risk capital upfront as grants to, see which innovations, which interventions work. Really building capacity for both non-profits as well as for-profit enterprises to be able to implement development interventions. Blended finance, which will be an important piece, how do we de-risk investment for private capital to come in using guarantees, using other structures like impact bonds, interest subsidies, and a lot of which I think the SAMRIDH team would touch upon. Fourthly, I think think about how we can move the needle beyond CSR for corporations. How do we bring the ESG lens a lot more and really find that shared value for businesses and actually, have them invest out of their P&L for development in their value chain. And then I think most importantly, while all of this is great, all of this needs to come together by creating a longer lasting, sustainable, enabling environment through work with policymakers, through work with governments at all levels, whether it's on building their capacity, whether it's on procurement, whether it is on building regulatory structures. So with that, I think last thing I want to say is that these are all different things which no one person here can do or no one organization here can do. I think we need more conversations like these at a sector level where we can zoom out and really say, these are the challenges that we need to solve in the sector. These are some of the interventions needed, and this is what USAID can do. This is what DFID can do. This is what IP Global can do. So I think really looking forward to the conversation and thinking about how we can move the needle on private sector engagement for healthcare. And I'll pass it on to Gautam with that to talk specifically on some of the things we've done and some of the things that are needed in the healthcare space.
Thanks, Apoorv. So yeah, I believe all of us here had been doing various deals, had been looking at the health sector from various points of view. If we go on this slide, might look a bit complicated, so maybe you can just take that as a reference, but let me speak. And as Ramraj said, today it's not really we would like to speak. In fact, I'm a bit apologetic that we are spending so much time speaking. We would really love to hear from you. But what exactly we love to hear from you, for that, let me put across, especially from USAID point of view, some of the questions that we had been grappling with since last at least 6 years that I am there in USAID, and in a way last 26 years that I am there in the health sector, mainly working with the government, whereas in USAID I started working with the private sector also. So there are two different worlds, it seems, when it comes to the health ecosystem. So if you look at the health ecosystem, of course the center is the patients and the citizen, but then there is the corporates who have either supplies and large corporations. We have the policymakers, the government and the central state and the local government also. We have research institutions which not only engage into clinical research for solutions, but also public health research in trying to see whether the translation of those innovations are making impact. We have the finances, mostly insurance till now in India is still a small player. In spite of BMJ and the latest data is almost 26% coverage, that is just 1/4 of the Indian insurance. So insurance is still not a driver of investments, financing, and those things. We have the not-for-profit sector, which plays quite a big, substantial role, and we also have the actual healthcare delivery system. So whether it's a clinics, diagnostic centers, and all those. Now, when we look at this ecosystem, very specific to the health sector, we really see that almost like it's a, I wouldn't say cross-purpose, but the way industries and investments look at the health ecosystem is really, really different from the way ecosystem, including maybe ESG investments and impact investors. What they are actually looking at is health businesses which are making profit or potentially can make profit. And because it is health, it is a background, not a result, but a background that, okay, some good work is being done. So what is being targeted at is really the profitability, and that is why investments comes in. And of course, health sector being very peculiar as compared to other industries, because other industries where it is driven by demand, health is mostly driven by need. And economic students all know need plus ability to pay is the demand. Now, where does this ability to pay come? Is it the insurance? Is it the government? So that makes the health system a bit awkward, and therefore the revenue streams also quite profitability. So here arises the risk for the investments. So when we look at investments from the private point of view, the ESG or impact investment, the major concern here is risk. Again, two types of risk: business risk regarding financial risk in terms of the structuring. But when it comes to the philanthropies and the development partners, what we are actually looking at is impact. And even the term impact, I believe the industries, especially looking at ESG and impact investors, define impact mostly in terms of people reached. But whereas in the development professionals like us, we look at impact, especially in health, more as lives saved or ideally quality of life is gained, the CALIs that we follow. Now here we are talking a bit different. So if we look at CALIs or lives saved, what we are actually dealing with is again in the center, but mostly either trying to influence the policy with the government and also working with the not-for-profit sector and some health sector which is mostly the government sector. The not-for-profit sector, maybe some private sector who are ready to do some good and not really earn profits out of this. So what happens is the investments for impact and investments for return, where risk is a concern, are really not talking to each other. And therefore, from our point of view, especially in USAID, I'll also explain very briefly how we passed through that journey of moving from a purely grants-driven organization to now we are talking about blended finance. So why we took this journey? What we felt really was there are these two concerns when we look at the entire healthcare ecosystem. One is we, especially from the policy and the development partners point of view, need to move a little away from deal by deal view of the healthcare ecosystem into a larger ecosystem. And therefore for us, what is very important is a blended investment at the ecosystem level, which may or may not happen at the deal level. So deal may be a blended deal, maybe a pure grant deal, maybe a pure investment deal. But can we really come together, all the players at the ecosystem level, to blend all our investments to see, one, the risks are taken care of by looking at the legal structures and some of the de-risking effort to ensure some revenue predictability and all that. But along with that, also ensure impact. And here comes the USAID story. I'm not sure if Neeta is available to speak. So so I'm taking over your part of the USAID journey. See, just as I said, USAID had been traditionally investing on essentially grants with not-for-profit sector and working at the policy level with the government. But what we felt was, in India specifically, when we look at health, the reach in terms of basic health care, outpatient care is only 20% of the government. Now, I think it increased to 30%. And when it comes to hospital care, it is around 40–45%. So a large chunk of the people will remain unaffected by investments from donor partners and CSR if we work only with the not-for-profit sector. So we basically wanted for the commercial sector to also come in, plug some of the gaps, mainly from public policy point of view, but also ensure that people actually get services affordably, good quality. Now for that, what we began with, and that is across USAID, is essentially loan guarantees. But very quickly we learned, and I think that is also a learning across globally, that loan guarantees by itself don't work. Why it doesn't work? Loan guarantee assumes that the leverage ratio is good, the company is bankable, and it is really debt financing that we are trying to de-risk. But what about the others? What about new companies with new ideas that come in which don't have a banking history? Debt can't play a role there. So either it is quasi-equity or maybe long-term 10-year patient capital that we have to look at. So we were feeling that our instrument of loan guarantees is really not working. On the other hand, as I said, loan guarantees not only don't really work because it might make the business proposition less risky and more profitable, but we are not getting the impact. And as I said, impact means not just people reached, but life saved. So there what we said that, okay, we'll try another instrument called the Development Impact Bond. So we had the Development Impact Bond in Rajasthan, run for 3 years, good achievements. But then what we felt was that Development Impact Bond, which assured 8% return and the investor got 8% return, is not really scalable. Because development impact bonds are so intense in terms of structuring, it becomes a transactionary approach, a deal-by-deal approach, and you really can't act at the ecosystem level. You either need some kind of an umbrella outcome funding for umbrella type of impact bonds so that you can have a family of impact bonds. Otherwise, one-by-one impact bond is really too much, not really economical in terms of the effort. We tried to scale that up through the government system. For TB nutrition, where the outcome payment trigger is a patient completing treatment and gaining weight as per the clinical standard. There also we felt that it was really appreciated by the government, but the government is ready to take it up more as grant-funded mechanism rather than a outcome-based funded mechanism, so not really a pay-for-results mechanism. CSR was finding it difficult because CSR laws doesn't really allow, in that sense, outcome-based where you can hold the money and spend later. And also, if you are purchasing an outcome where there is unit price of an outcome, there is no audit trail. So how much on salaries, how much on these things. So CSR was an issue. We couldn't really get CSR money to finance the outcome. Although, unlike the development impact bond in Rajasthan, 8% return, we really calculated here the returns were in the range of 16 to 18%. Now, if that could have been marketed, I think investment should not have been a concern. But here the concern was outcome funding. And there the government, which is the ideal outcome funder, I think the government procurement policies are not designed to procure impact. It's designed to procure services and goods, products and services, but not to procure impact. So, so with all those constraints, we started this blended finance, where we were looking at both deal-to-deal blended finance as well as the ecosystem level blended finance. I won't go much into details because SAMRIDH team is already here. They will speak a lot. But in all this, we are still grappling with what is really the mix, whether it makes sense to have deal-by-deal blended or ecosystem level blended, and how to really put all these two major concerns together. One is how to achieve impact and how to de-risk. Are these two separate? Can you have a business model that is both de-risking as well as impact? Or you need to focus on blended finance for de-risking and have separate grant funding for impact? So I think these are some of the questions I would really love to hear from you. What is your field level experience in all this? So I think we have taken a much longer time, but I'll just stop there. Thanks.
We have the SAMRIDH team speaking next. Manjunath, if you can.
Hello, yeah. Can you go to the next slide, please? Yeah, good afternoon, everyone. So, I'll be talking about the opportunities in healthcare, what are the key challenges in some of the sectors, and how we have tried to use blended finance within SAMRIDH. So, can you go to the next slide? So, if we look at the WHO health systems framework, what are the 3 or 4 outcomes that we want to achieve? One is the improved health, that is both the level of health at the population level and also equity in the health levels achieved at the national level. And we want the health systems to be more responsive to the patient and citizens' needs. And while they were planning to achieve more improved health, we also want to protect them financially and socially. And whenever the healthcare is being delivered, we want to improve efficiencies. These are the 4 broad goals of the health systems. And if you go to the building blocks of the health system, like service delivery, medical products and technologies, we'll see a lot of key challenges, or you can look at it as an opportunity. So in terms of service delivery, we have got inadequate infrastructure, which COVID brought out dramatically. There is rural-urban divide, there is poor quality of service, poor quality of care, and accessibility and affordability are issues at the service delivery level. For medical products, we have low indigenous capacity to produce medical equipment. We are still highly dependent on imported components or imported equipment for delivering healthcare. And health workforce, everyone highlighted the COVID also again brought out low doctor patient population ratio, low nurse population ratio, but there is a lack of skilled manpower across the spectrum, paramedics, ambulance drivers, radiation technologists, any skill set you need, there is a lack of healthcare workforce. And in terms of healthcare financing also, as Gautam was saying, the insurance penetration is low. There is high out-of-pocket expenditure. There is low public health spending. And even the health information systems, we are not using the data or analyzing them or compiling them in a way to see where resources need to be devoted. And the leadership and the management systems are also not agile. The regulatory framework is weak. And there is lack of accountability, especially in public sector. Private also there is, but public even more so. So, if can you go to the next slide, please? So, one thing we also want to emphasize is like blended finance is not a panacea. It's not a silver bullet that will solve all the things. So, if you see the axis blended finance, some interventions are less amicable for blended finance at this stage, at this evolution or at this stage in our country. They are less amicable. And there are some sectors within the health sector that are more amicable for blended finance. So, for example, mental health, it's still in its infancy. It is still taking roots to be delivered at scale at community level. So, there blended finance may not be a good instrument to be used. Coming to primary care and across like healthcare workforce. So if you see below the axis, there are some instruments that we have tried to experiment and see how blended finance can be done. So we have given pure grants to social success note. We have used all the various instruments. RBF is results-based financing. Result-based financing, impact bond, RBF leading to equity or debt raise. Returnable grants also there. So it is not a one-to-one correspondence like digital health doesn't mean we are going to do RBF leading to equity, but we have tried to use that in that sector. For example, medical devices, we have used returnable grants, we have used loan guarantees. We have used different instruments for that. So the basis for blended finance is the business model that is underlying the intervention. So in some business models, there is no cost recovery. And in some, there is both cost recovery and financial return. So the goal of our facility has been to get to the middle ground, literally and figuratively. So if there are some non-profits and others who are doing grant dependent and they're only giving services, so we try to use blended finance to see if they can do partial cost recovery or try to reach break even at least. And there are some profitable enterprises which have expanded in tier 1 cities. So we see if we can use blended instruments to motivate them to go to tier 2 rural population, to serve the vulnerable, where even if they don't make financial return, at least they can do break even at that stage. So our goal has been to bring them both across the spectrum from non-profit to for-profit towards a middle ground where we want to generate impact. So impact first, return later, that's our guiding principle in involving. So coming to the different health sectors, I will just briefly talk about 2 or 3 sectors where there are opportunities and there are challenges, and we can discuss as a group how we can use blended finance and what other mechanisms can be done for this. So can you go to the next slide, please? So yeah, medical devices, the opportunities are huge. As you know, India is planning to become a $5 trillion economy. We have a growing population. We are experiencing epidemiological transition. We are going to be hit by triple burden of disease. And all this needs services to manage. All this needs preventive services, curative services, rehabilitative services, even hospice services to be able to manage this increasing burden. And the growth factors that I'm telling is applicable to across the building components that I had showed, but especially for medical devices. So there is increase in demand, middle class is increasing, there is more disposable income, Home healthcare has become, especially after COVID, home healthcare has taken increasing this thing. So those will need medical devices. And health insurance, even though it is not to the desired levels, it is expanding in scope. We have got digital health insurance platforms like Ditto and others. We have got PMJ, Ayushman Bharat, and private health insurance companies are also, FDI also has been relaxed. So there will be more health insurance uptake also in the coming years. So we expect this is from the investment opportunities by Niti Aayog. So we expect around 37% CAGR, and the industry will grow from 10 billion to about 50 billion in another couple of years. So, and we are also looking at an enabling environment by Government of India, like right from Made in India to Startup India challenges. Government has also brought out performance-linked incentive schemes. They have allowed 100% FDI in medical devices. And as the map shows, they are trying to set up manufacturing ecosystem clusters across India so that dependency on imported goods reduces, and we can increase our own capacity to address, and also to export medical equipments to Africa and other countries. So can you go to the next slide? So although opportunities are there, we still have a lot of challenges that we experienced in our 2 years of trying to fund medical devices companies. So some of the solutions that we funded were COVID focused, and there was high demand volatility. Like after the Delta wave, many devices that were there, they increased their capacity, but when the cases came down, they couldn't find a market, and business and market challenges are there. Procurement of raw materials, like right from some simple chips, microchips, to zincolite, which goes into oxygen concentrator, etc. There was procurement and supply chain challenges, which the small enterprises, startups, innovators, they had to struggle with. Rental market has not evolved in India compared to Western countries, etc. So if you see the CAGR, it will become $50 billion, but the percentage of rental equipment market will come down actually, because Indians prefer owning assets rather than renting them out and going faster around. Policy environment, one thing we have noticed is also getting CDSCO and etc. Domestic regulatory clearances is much easier. Going for FDA and CE certification, etc. is a challenge for Indian companies, because they also carry more market weight in the thing. And the government has set up government e-marketplace, but navigating that and getting orders through that platform is a challenge for this thing. And as Gautam was saying, development partners, they look for impact. And those who are in pure businesses, they have a hard time understanding what is impact, how do we measure them. So that has been another implementation challenge for them. And the other implementation challenges are, they usually have a small team. The founder is the sole decision maker. There's resistance to adoption of new medical devices in the hospitals. And there are some financial pain points also, like working capital. They need long-term debt to set up manufacturing capacities. They require growth capital, which is affordable for them at their early revenue stage of their companies. So these are some of the challenges. Can you go to the next slide, please? So telehealth is another, we have funded a couple of telehealth ventures. And this also has gained increasing acceptance in India because of COVID and the positive outlook, the deeper penetration of smartphones and internet. And also the government is enabling through ABDM, they're trying to encourage digital health. And they also set up e-Sanjeevani platform, etc., which encourages. They also came up with the telemedicine guidelines in March 20. So those things have helped to boost the telehealth segment. And the digital healthcare market is also growing at 20%. So there is opportunities there also. But the problems that they face, can you go to the next slide, please? Next slide. Yeah, so the challenges they face is market penetration is difficult, in the sense there are alternative channels, right from quacks to pharmacies to other clinical primary care givers. So That's one challenge. And insurance doesn't cover OPD in India as of yet. So there's a telehealth, they don't get coverage or reimbursement for those. Under the policy, they have got challenges like if they use AI or ML, or if they use clinical decision support systems, etc. What are the policy and compliance issues with that? What are the compliance issues with respect to e-prescription? So those things need to be done, and also the data protection, which comes under the ambit of the data protection, but those are the issues that they frequently deal with. Implementation, again, because of their team size and this thing, setting up demonstration sites and resistance to digital health adoption or other challenges. That is. Financial is again same. They have not been able to show a sustainable business model, and they need capital also for that cash inflow. So, can you go to the next one? So the next sector I'll be talking is about the diagnostics. So diagnostics also is you can say it's also the market is going to increase and opportunities are going to increase in the diagnostic space, because everyone is moving away from everyone is moving towards evidence-based medicine, and most of the 70% of the clinical decisions are based on some lab tests and lab reports, etc. So the government is also setting up a lot of labs at the district level through the PM Abhin health infrastructure mission. So there is a lot outlay for setting up public health laboratories at district level and block levels. So that is going, and the menu of tests available also is expanding in scope. And POC diagnostics have become increasingly accepted, and not only POC. Earlier POC was being done by a healthcare worker, but now with COVID, even home test kits have also made proliferation. So there is another market for home-based testing and other stuff. So that also is expected to grow at around 12 to 13 CAGR. And if you compare with the Western countries, etc., the number of tests per 1,000 population is very, very low. So there is still room to expand within this thing. And the preventive health checkups, etc., is not as much as we need because of non-communicable diseases, etc., is going to increase. We will need to do more preventive and routine monitoring checkups, FBS, hypertension, other stuff. So those there is also scope to expand in that sector also. Can we go to the next slide? Yeah. So the challenges are within the business environment is there is high fragmentation. There is also quality and accreditation is an issue. Only 1% of the labs. Report estimated there are 1 lakh labs in India, both standalone, hospital-based and diagnostic chains, but only 1% of the labs are accredited to NABL. So there is low entry and exit barriers to set up a lab, and there is a limited understanding of newer technologies like genetic sequencing or molecular immunological tests, etc. So those understandings are very less. The other implementation challenge we had was again with the impact measurement, because a diagnostic lab, they only talk about what number of tests they have done or the number of samples they have processed. But how does that translate into what Gautam was talking about, QALYs or DALYs or lives saved? That is very difficult for them to estimate, and that's also a challenge for us to do, how to go from what they are reporting to us to what the donor or other agencies require us to report. So how do we bridge that? So that's also going to be a challenge. And as I said, the lack of skilled talent, right from phlebotomists to those who can run genetic Novosec sequence machines and analyze, interpret the data. There's a lack of skilled talent across that spectrum. Financially, there is, for example, INSACOG, they set up around 28 labs, and they are only processing 1 to 3% of the samples. Also, WHO wanted 10% of the COVID samples to be sequenced to see for variants of concerns and variants of this thing. So it was very low, and the turnaround time was also 1 week, 2 weeks. So even though they would get those sample results, it would have been already late. The virus would have mutated. So those sort of investments need high capital investment to set up. It goes into crores of rupees, Novosec sequence and others. So we have we have invested in some of those newer technologies and sequencing machines, and they also require working capital at affordable rate so that they can, because some of the samples they are being tested is through the government, the payment cycles will be delayed, so they would need working capital assistance. So I come to the end of my talk. So basically what I'm saying is there are huge opportunities in India. There a lot needs to be done to increase the health equity and healthcare service delivery in India. But how do we encourage private sector through blended finance, and how do we balance the impact and the financial return or the cost recovery? So those are the bigger questions which we need to answer. So we have just taken the initial steps in that. So thanks.
Yeah. Okay, I just want to sort of come in here. I think this is a good point for us to have a broader conversation. I think we've got a good sense of some of the spaces in healthcare, and by no means are we here to suggest that blended finance, already he's spoken about. It's not a panacea. It's not a hammer which is looking for a nail. There are specific situations where potentially some of this could be useful. And there are a variety of ways that blended finance can be used. I think Dr. Manjunath has given us some flavor of some of the spaces, whether it is telemedicine, whether it is devices, diagnostics, where there could be some potential and some work has been done. So what I wanted to do is, I'm just using this slide loosely just to kind of, sort of anchor the conversation. In terms of what is your sort of experience, is this something that needs to be accelerated or scaled, or, and how do you see it, and what has been sort of your experience, some of you who've been in the space, how do you really see this, and is this something that sort of deserves, a far greater degree of amplification, and what spaces do you see are the lowest hanging fruit? So maybe I'll just stop there and maybe open it up for some conversation and interaction from other people. In terms of both for and against. So, by no means are we here to sell the whole idea of blended finance, but, just get your sort of thoughts on some of these. So maybe I'll just stop there and maybe, get inputs from all of you here, who are here in the room. Unfortunately, we're still facing some technical problems, so it's possible that we may not be able to get some of the people on the call to speak for now, but at least for those in the room, if there are any specific inputs or thoughts, feel free, and then we can have a more open conversation. Yeah, Karthik, please.
No, thank you very much. This is fabulous to see this granularity of different instruments for different use cases. In this case, within healthcare, and based on the experience of different transactions that have happened. So I think, look, at a conceptual level, as Mr. Gautam said, that there's this challenge of, they say, impact and leverage, right? That some instruments give leverage on the blended finance side, on the debt side, but the impact bonds could be giving more impact, but the leverage is missing. But that being said, when you really get into these specific instruments and start mapping out, it's sort of laid out in terms of the level of development of that sector, the availability of commercial capital. Another way, this is what I wanted to add and layer on to the discussion, is by the stage of the enterprise. So one is the sector or the subsector, but regardless of sector, within health, you have very early stage enterprises who are going through incubators. Now those incubators, and it's linked to regulation, could take CSR money, and CSR money can go directly into those enterprises as guarantees. And there's some ambiguity on that, but they're saying it's a contribution, doesn't have the utilization certificate. Someone mentioned, I forget whom, that regardless, the debt challenges are very high. So it's, I think Mr. Gautam only mentioned it. But for medium-sized enterprises, you do need to enable them with low-cost debt. So then, that's great. And none of this includes NGOs. So for NGOs, clearly the solution is platform approaches through blended finance. So how do you do that? So I think it's wonderful to have this discussion, but we need to analytically keep going deeper and deeper. We're doing some research on this with Vilgro on the life cycle aspect of it, and all this other research is there, to then start coming up with 4 or 5 concrete recommendations. The last one I wanted to make is the government is starting to get really interested in this, right? From the budget announcement, they talked about results-based financing for education and healthcare schemes. So they're looking at it more from that perspective. Mr. Kant is talking about in the G20 all kinds of references to these classic guarantee structures and so on. So for the first time, they're saying, tell us what more we can do. Yes, for Educate Girls and the TB nutrition bond and things like that 7, 8 years ago, they weren't that interested. Now they are interested, both in evidence of interventions and simplified like solutioning, one level simpler than this. So that would be my submission, that how do we then take this and really come up with 4 or 5 buckets of ideas, and then that can advance the industry.
Yeah. Anyone else in the room? Any specific spaces, some experiences and opportunities?
Yeah, hi.
Maybe you can just introduce yourself so that for the benefit of others here.
Yeah, good afternoon. My name is Mausam Pal Chaudhary. I'm one of the founding partners of Ossimum Partners, a healthcare-focused investment platform. So I wanted to build upon your point and going back to the presentation. Typically, what I've heard, we tend to believe that most of the innovation from a private company's perspective, we tend to believe most of the innovation comes from startups or early stage companies who are making breakthrough technology. I have been investing in mid-sized, small SME companies who are cash flow positive, who have been running their businesses for quite some time, but they're small. But all of them would have a small portion of the business which is novel, with something new, which requires a lot of market creation and education, and which our products are offering, which can make a substantial health impact. Be it, for example, in pharma companies we are working with, they would have some novel products which would extend or would give a better therapy outcome. But these companies on their own are not efficient to carve out some part of the assets or team to go out and spread the awareness in the doctor professional community, which is lacking, because otherwise there are no therapies or there are mistreatment or price gouging which happens from the conventional way. So there is a need for these matured companies, although they're very small, who have a common good problem. And collectively these companies, maybe 2 or 3 or 5 of these companies who are into these novel products, all of them may band together to work on the initiative, to create awareness. But the question is, can they team up with somebody like the financer or grant provider who think there is opportunity to help these small companies coming together to create a market and extend the delivery. So it's not just the small innovative startup companies. There are enough opportunity in the mid-size SME companies. They just don't have the wherewithal to on their own go and make the market.
Yeah, before, I just thought I'll points. I just could hear you're from Okimum.
Yeah, Mausam. I'm Praneeth's colleague here.
And, and by no means I'm a health expert, just really the outside. Which are more of the sweet spot that we see a lot of, PE guys investing. Whereas our data from IIC shows, particularly in early stage companies, they don't lend themselves to traditional models in VC investing, primarily because a lot of these companies, whether we are looking at companies in hardware, whether we are looking at other companies which are trying to bring together very highly innovative solutions, risks as well as the ability to generate sort of outsized returns with scale is something which is not very easy. And therefore, when I look at data from IIC in terms of health tech investing, especially early stage, it's really, other than maybe, I don't know whether there's someone from Health Quad here, there's just barely a handful of funds which are doing anything in the early stage. And rightfully so, because of the nature of the risks, as well as because of the nature of returns that LPs are expecting. So obviously, if you're expecting very high returns, and the kind of risk that you can take is also limited, it's really a closed box solution. The question that I'd like to put to you before, or rather, once Karthik and others come in, is really that that possibly your early VC type investing may not be what the traditional model for health could be. It could be for other sectors. It could be for education, it could be for financial inclusion, but maybe it's for health. much more of a hybrid model, which really tries to think of a senior subordinate structure where the subordinate really is either much longer than that, or he is willing to take subordinate returns after, a certain, so, you have senior returns, maybe you have subordinate, or maybe you have senior returns carry and then subordinate returns. So that's something I just wanted to leave on the table. Karthik, over to you, and maybe we can help, speak to others in terms of what their thoughts are on this. Because what you're saying is, you have large companies, is there something that they could do? I'm saying, can this become a central part of how we support innovative health investments, particularly early stage, which could be very high on risk, at least as an outsider, but somebody who's been in the corporate sector for long, they do look reasonably high on risk. So maybe I'll just leave it there, Karthik, and then some other people can speak. And then we can maybe go on to the other topics. Yeah.
Maybe I don't need it.
No, I'll just hand.
No, I just had a clarification with respect to how we are defining impact in the context of healthcare, right? So I think it's quite important for us to see this as an integrated solution and start developing some kind of systems thinking early on. So for example, when we say that the scope for blended finance in primary care or mental health is sort of relatively low, or because impact might be high, but the returns are actually not that high. I think it's quite important for us to see it as a collective, because if we see mental health as an intervention, and if we define the use case for mental health as something that is clinical depression or anxiety, which requires specialized skill sets and therefore requires access to tertiary care, then I think we are sort of defining the use case for mental health accordingly. But if we see mental health as more of a community-driven intervention, which can be used as a way to develop healthcare workforce capacity in combination with primary care, maybe the collaborative effort to structure a solution in turn would actually render it more attractive for blended finance. And I just wanted to leave that as a thought, because it's quite important to take a solutions-oriented perspective as opposed to defining this as a digital health intervention or a med tech intervention. That's about it. So.
No, so it's been, of course, health tech is taking its own evolution in India, and digital health takes a certain time before adoption happens. And of course, with Jio and other telecom providers essentially providing the cheapest data globally in this country has essentially helped accelerate it. And of course, with COVID coming in, it got further accelerated, and we all adopted digital health in different forms. We spoke about some of those in the previous presentation. And in terms of returns, risk reward, I think, so healthcare is now coming of age. We are seeing, we've backed certain models within the overall healthcare ecosystem, and we back disruptive models in the space. And it's been super exciting to see some of our companies have, we've also taken some partial exits in some of the companies. So companies have delivered stellar returns across our portfolio. Most of our companies in them enough scale advantage and essentially potential to sort of create operating leverage in those businesses. And we've seen that disruption across different verticals of healthcare. So we have, like, just to sort of give quick two, three examples. So we have like India's leading data analytics company. We have India's largest medical B2B supplies platform on our, in our portfolio. We have a couple of AI companies, one on AI in the imaging space, and second, since we spoke about mental health, using AI technologies in the form of mental health chatbot, where you don't need to wait for a therapist appointment for 4 weeks, and it's like your 2 a.m. friend or 4 a.m. friend, where you could essentially, and it's a clinically validated solution to sort of reduce your anxiety, depression level. So we have now seen solutions across the healthcare ecosystem, and each of these companies understand that they have to commercially scale, drive adoption, and which will essentially then lead to higher value accretion and therefore returns for the investors. And just to bring in the blended finance angle, so we've seen in some of the companies impact bond, because all of these, healthcare naturally lends itself to impact, and of course some of them have a much deeper impact than others. But if there is a long-term financing available for some of those companies, because the commercial use cases take certain time to develop when you are essentially trying to prove certain validation through clinical approvals, you could essentially take benefit of impact bonds, etc. So I think blended finance has a role to play in the healthcare space overall.
Hi, my name is Kshama Kothari. I work with Social Alpha. I lead the health team's work there. I have so from our perspective, where we work with companies that have an early stage prototype and are looking for de-risking funding or pre-seed investment, we work in sectors of primary healthcare, assistive technologies and rehabilitation, mental health and wellness, and now increasingly looking at how to look at independent living for now that we are the most populous country in the world. Very early stage companies, they need to be incentivized to look for a tool apart from grant and equity. Grant and equity is easy to raise, but not necessarily the best choice for business always, because when they raise for grant, the essential ask for every, say, request for proposal is articulate your impact. But they're not necessarily looking for impact. They will be impactful companies, but that hand-holding, if given to them, they can probably do better by presenting their work from a non-business perspective. It's not their core strength, and we have seen companies struggle at it a lot and delay in their grant applications. So if, as a part of this grant, returnable grant, blended financing, if that support is provided to the company, they might do better at telling you what they want to do and how they'll achieve impact. Returnable grants are the ones that have found most acceptability because they're easy to understand. Also because every time they raise money, grant or anything otherwise, they have to go back and report to all their stakeholders who are on the cap table. So there is a lot of hassle of paperwork and process because of which they don't want to take it, while that might be of benefit to them. So this operational help might go a little way ahead in bringing more number of companies and innovators to take this kind of financing. So one important point that Mr. Gautam mentioned is about impact articulation. And honestly, even at our level, we struggle because we are working with companies before they're going to market. Yeah. And so we are trying to look at if we can take time as a construct. If we can advance a company from a certain stage to a market-ready stage in a certain time, can that be measured as impact? Because that incentivizes the company also to build faster and become relevant as soon as it can for the market before its time is elapsed. So, and even after all of this, we are working with probably the minority of population which has a health-seeking behavior. So the companies are building for people and population who know they need healthcare. Yeah. But a large part of our public health is focusing on solving for problems that people are not aware. Yeah. And that has a larger role for blended financing. Yeah.
So Shama, before I just hand over to Karthik, this is a question maybe Pur, to you and other people in USA and others. 1 second, we just running a bit. So what Shama is also saying, and it looks like articulating impact is really perhaps doing more of stuff that you know well, which is obviously always an easy sell. And as someone who's been in sales for a long time, just selling the same thing that we all know well is much smoother, much easier, much more comfortable. But really when you're trying to innovate in new areas, perhaps either solving for problems which are more difficult to even articulate, or solving for problems whether you don't know whether that solution will be there, but potentially if it is there, it could create very significant degree of impact. We can't expect BAU regular investors to come in to sort of kind of fund some of this, or you will want development funders with a vision and maybe a creative thought which is somewhat significantly outperforming what the regular is. So the question is, how can maybe, Apoor and Gautam and others, development funders like USAID and others, really build this culture where you're actually supporting innovation for impact rather than scale for impact in a way. So what I'm saying is, which is not to say that scale also does create impact, but sometimes when you want innovative solutions, the runways, the kind of support that is provided, the kind of, the runway that is available, is much longer, and you actually have to guide these organizations much wider and much deeper. So is that something maybe Gautam or Apoor, you guys look at? And because once 2-3 people do this, there are possibly others who can sort of use those toolboxes and kind of try and do that on their own. There's a last question, and then I'm sorry, we'll have to move on because we are running a bit late. Karthik is waiting.
Yeah, true. We are actually short on time, but I believe very interesting discussions, and especially from the health sector point of view, I really would like to express some of the thoughts that came across, which is very clearly coming out that what we are looking at is really not a financing solution, but a whole gamut of solution which addresses the ecosystem, and financing is one part of it. Mainly as we had been articulating impact and how we look at impact, and can we look at some intermediary outcomes, focus on that and leave impact for later. So that is interesting mainly because the development partners' typical projects are 3 to 5 years, and in 3 years you don't save lives, but still we measure saving lives. The maternal health impact bond that we had in Rajasthan was all about a hospital getting accreditation. And we did forecast 60,000 lives saved, and we are tracking, we are already touching 50,000. So there are solutions, means it's not that we are doing something intermediate, we are not really saving lives, so can we leave saving lives? There are softwares, list software, other software that can actually link whether it is scale, whether it is just reaching out to more people. It's not always that we have to focus only on innovations. Even scale can lead to certain lives saved measures. And it is very much doable. But that is where I think we need to come together and educate each other. Because if development partners had been doing this since last 60 years, there's no reason why the impact or investment community can't really do it. So let's share, look at that, and also some of those solutions around this market creation and all. It is very clearly coming, what I also presented in terms of the ecosystem. The investments need to be looked at from an ecosystem point of view. So creation of a market, creation of awareness, some legal measures will de-risk, will lead to scale, will lead to more profits, will also lead to more impact. So how we really bring this story together and have something measurable is what we have to see. Also the last point around innovations, I think again when we look at innovations or startups, we look at how to finance them, and okay, scale is something that will be achieved. But any innovation needs adoption, and adoption is an essentially business process reengineering activity. Because the moment you have something new, you have to either adapt that, change that something new to fit into current business processes, or change the current business processes to adapt that. Now that is something which I really see with this conversation cannot be part of one investment case or one business model. But at an ecosystem level, if we invest on those things, maybe it will help this. So I'm more and more getting convinced that we really need to look at it from an ecosystem point of view, and let's see how we can create certain forums, platforms that can facilitate that.
Yeah, thank you for that. I think this is a question that we can keep on debating, and we've had multiple conversations with Apoor in terms of really, in my own very different way, the way I look at it is there's low risk and high impact, and there's also high risk and potentially high, if not higher impact. The question is the low risk, high impact, relatively speaking, is a market which is much more familiar, whether the high risk, high to potentially higher impact is a very different space. If we are able to get more concessional, longer-term capital, which allows for both commercial investors as well as entrepreneurs to take higher risk, there is a possibility that we will be able to create a far larger, more innovative ecosystem. Because one of the biggest challenges that I see, at least as an outsider, is the availability of LPs who are providing concessional, longer-term, subordinate capital Whereas the expectation from the funds is that they will create disproportionate impact primarily because they sit under this sort of label of what is called as impact investing. So genuinely for impact investing to get even more athletic, I think while VCs need to, I think there's a need for us to also think about, how LPs kind of look at this whole market. I'm just going to now hand over to Karthik. I think it's been a good discussion, but I'd request you all to keep coming so that we can keep this conversation vibrant. Over to you, I think, to start off with Karthik.
Thanks a lot, Ramraj.
Just set some, just so that, we are a little late on time. So how much time do we have? 20 minutes? 20, 25 minutes, Karthik.
I've timed myself to 20 minutes.
Because I know your slides are very, very, if I may say, deep, quite involved and quite, so I just want to be sure that we are trying to keep up to the later time, whatever it is that we are working on. Yeah, over to you.
Yeah, I'll skip past most of the stuff that has been, I think, spoken about by the previous speakers. So, the next set of slides are effectively a story, and this is taking a slightly different perspective. So, this is a service provider perspective and a care continuum perspective. So, if you could just go back to the earlier slide. I know we are hurrying, but maybe the first slide. All right, thank you so much. So here, what I've tried to show is that there is a care continuum approach that we need to actually be looking at when we think about a disease condition or probably what we are trying to really address and define as impact. And as we look at this care continuum from promotion and prevention all the way to the onset of illness and the diagnosis, the decision to seek care that Dr. Sharma spoke about, what we realize is that there are a host of challenges that the consumer is really facing, who is really at the center of what we are trying to address. And these three problems can be really bucketed into those related to the accessibility of care, affordability of care, and the quality of care. And I think a lot has been spoken about the availability and the shortfall of the primary care infrastructure. Enough has been spoken about the fact that human resource capacity is probably inadequate, and the level of skilling both of the clinical health professionals as well as the paramedical health professionals is really low, and this is something that needs to be addressed in a systemic way. But just one point around the quality of care, I think what is increasingly coming out is that there is lack of a shared narrative. And I think this is where the key opportunity for blended finance really comes in. What we need to be clear about is what is the kind of outcome that we are actually looking for, and then try to center the solution in accordance with the realization of that specific outcome. If you could go to the next slide. Sorry. So this was part of a study that we really undertook to really try and understand what are some of the key operating models at the level of primary care. So this is a busy slide, but just stay with me. In the rows, you will see that there are 4 to 5 critical enablers for a sustainable, impactful primary care operating model. There is clearly the need for financing, followed by manufacturing of medical devices and technology. Distribution is a critical element that we need to take into account for medicines as well as essential commodities. And finally, the triangulation of all of that into really providing effective, efficient healthcare delivery. Now what we did was we tried to actually really position that against some of the models that we are seeing in the market. And so the 5 columns, low cost, high volume, high quality, high cost, low volume, specialized care, all of these are basically talking about the kind of operating model which can be used probably at the level of primary care, but really across secondary and tertiary levels as we are thinking about providing preventive care or really addressing diagnostic or basically multiple aspects of the care continuum. Now this is quite critical to understand because it really helps address what is the key pain points within the patient-centered journey that we are trying to solve for, and which one of these models can be realized at the level of primary care. If you move to the next slide. So in this slide, this is basically a subset or a universe of 11 models that we see that basically combine financing, distribution, manufacturing, quality healthcare service delivery, along with those really 4 to 5 operating models to come up with what is really applicable at the level of primary care. So if you look at these models, low cost brick and mortar clinics which are really operated by a clinical officer or a medical doctor and a nurse, integrated low cost brick and mortar clinics which are really providing integrated care, and they really focus on prevention, promotion as well as treatment, and then so on and so forth. The point that I want to make over here is that these 11 models are seen as the key driving sustainable building blocks for primary care, and a combination of these together with the blended financing types of solutions is going to be critical for us to actually really scale and sustain effective primary care service delivery. To the next slide. So what we then did was we tried to position the 11 say key types of primary care models against the continuum of sustainability as well as impact. Impact was largely driven by how are you really trying to address the 3 systemic barriers in the context of the care continuum, and sustainability was largely driven by how self-sustainable can that primary care delivery model be. So there is a deeper dive available to really try and map out what is going to be more sustainable and more impactful. But for the purposes of this presentation, the focus has been on 3 things which have been circled. So if you could go to the next slide. So this is a busy slide, but I'm just going to explain through an example in the top row. Integrated low-cost telemedicine. Impact is really defined in the context of how we are trying to leverage low-cost telemedicine solutions to really address access, affordability, and quality care. And here we see that the rating for a low-cost telemedicine proposition is quite high. And then if we move further towards the right, we talk about the potential sustainability and scalability of the solution. What we see in terms of sustainability is that there is basically scope for higher margin at the secondary and tertiary levels to really improve the sustainability of the telemedicine facilities by creating this kind of a care-connected network. And the spokes, which are relatively low cost, really allow them to be scaled because they are providing targeted care. And some of the risks and key enablers in this regard include the fact that sizable, consistent patient volumes are required to break even. This is where it is quite important to sensitize the broader community around the kind of health-seeking behavior which is needed for them to seek really positive, transformative, lifestyle-modifying behaviors. And the second piece is that the patient volumes tend to remain relatively low because of their lack of familiarity with the telemedicine models. And this is where it is quite important to advocate and sensitize the patient around the kind of interface which is needed to really deliver healthcare services. Now, I don't want to go through all the 3 models, but it is quite critical to understand that there are multiple examples by which primary care can be operationalized. This can take a disease-specific approach, it can take a care continuum approach, or it can take an infrastructure approach. But the point over here is to keep the patient at the center and trying to actually design a solution which is going to really help decentralize some of the care continuum and the capabilities needed is likely to work as a successful primary care proposition. The next slide. So as we have seen the universe of primary care models, what we see that in terms of the kind of innovations that are really available at the level of primary care, there are potentially three opportunities for blended financing. The first is that there are multiple providers working with the government who really face working capital issues. And here the kind of transaction which is really proposed is the working capital fund. This is particularly applicable to the point of care diagnostics which work in collaboration with the public health facilities, hub and spoke diagnostic centers which are really there for non-communicable or specialized diseases which really help with the screening, detection, followed by diagnosis and treatment. The second big opportunity that we see is that there are really large not-for-profit healthcare providers who are driving impactful solutions at the level of primary care, and there is a need to actually scale these services. In that context, outcome-linked grant is really quite critical, because we have to realize that while the universe of solutions to address a specific problem is large, what is truly impactful is not driven by its potential to scale, but it is really driven by the potential to actually really solve that issue. If it is going to be effectiveness, if it is going to be care coordination, if it is going to be improved outcomes through reduction in mortality and morbidity. So from that perspective, the applicable models are largely high impact not-for-profits who are working in the space of tuberculosis, maternal mortality, who are really trying to lower the disease burden through the kind of innovations and through the kind of programs that they bring into this. And the beauty about these kinds of solutions is that they take a systems-oriented approach. So there is a focus on really building healthcare skilling, there is a focus on really leveraging technology, and there is a focus on partnership to really define what the broader governance and the shared narrative around that partnership and the objective of that partnership is well defined. And the third piece is largely healthcare enterprises who are in need of debt capital to really expand their offerings. These are low-cost debts coupled with really outcome-linked interest buy-down. By this, there could be telemedicine solutions which are really trying to reach hard-to-reach areas where they are providing care to those who are basically underserved. In these kinds of contexts, right, these companies require access to low-cost debt, and if they are in if they do demonstrate that their intervention does result in some kind of improvement in the outcomes, then they should be incentivized through an interest buy down. So basically these are the three critical opportunities from the universe of primary care models that we landscaped during our deeper dive to understand the primary care ecosystem. The next slide. I think the next series of slides are basically a deeper dive into really how these blended finance instruments can be positioned and basically the workflow of it. I don't want to go into a whole lot of detail. It is quite visual and it's a re-emphasis of what I just spoke about in the earlier slide. What I would like to do is basically in the next slide, if you could go there. So I think here is a solution where we have a portfolio company, Neurosynaptic, which was in a position to access low-cost debt, really to improve service uptake in the underserved segments of the market. And what we saw really very clearly was that through the kind of telemedicine solution, access to primary care and community care, including positive health-seeking behavior, was really improved as a result of access to debt. And now the company is really there in a more mature trajectory as a result of this kind of a transaction. So here is an example of a social enterprise working in telemedicine, basically at the level of primary care, who has accessed blended finance to really scale to a different growth pathway. And if you could take the next slide. The last slide has been spoken about through the care continuum of blended finance, and I'll be speaking about this in the context of the case study on mental health. But basically, outcome-linked grant can really help healthcare providers monetize the social impact. This is particularly important for some of the conditions where we see that the demand is not very high and where it has been slightly difficult to demonstrate what is the kind of impact that we are creating. And it is quite critical to really enable these kinds of solutions early on, and to figure out not just how they can be scaled, but how they can be incentivized to actually continue to innovate and provide contextual and specialized healthcare services at the level of primary care. I'll be speaking about this in greater detail as part of mental health and as part of a deeper dive on the case study. So the next slide. That's it. So I was good.
Thanks, Karthik. Apologies, but in case if anybody else would like to, just jump in here for any questions, clarifications, feedback, please go ahead.
So one of the points that was discussed over here was, you can hear me, right? Yes, sir. So working capital financing for expansion, but what about working capital financing for sustenance? Like the hospitals are running into liquidity gaps even today, right? The smaller ones as well as the larger ones, particularly because of the government schemes and the cashless facilities that are coming in. How do we address that particular aspect?
So this is with respect to primary
and tertiary as well for that.
Does anyone else want to take it? I'm not very sort of comfortable answering that. It's a question related to tertiary care and secondary care. But Amit, do you want to take that?
So before I answer that, I also wanted to give an example of the working capital facility potentially being used in the case of TB. TB is obviously a very high disease burden, costs a lot, especially in the private sector. How potentially non-profits which are trying to solve or trying to address TB at the community level, how they themselves are running into working capital shortages. And these are large non-profits. These are not like small non-profits. These are like some of the largest non-profits. They dip into their own corpuses just to be able to keep their operations running. So the working capital challenge is not just a private sector challenge, it is a non-profit kind of challenge as well. There is one solution which we've tried. I'm not saying it is the perfect solution, which is something that we are doing in Tanzania. So Tanzania has about 1,400, if I remember correctly, these numbers, 1,400 faith-based hospitals. These are small hospitals which depend almost entirely on the public health insurer paying them back. And just like here, the public health insurer takes their time to pay these people back, right? So it takes up to a year in some cases. Also, about 40% of the population actually depends on these faith-based hospitals. So it's not like we can get away with not paying them. So they do need to survive. And lastly, also there are cases just like here, where if the hospital raises a claim for, let's say, $1,000, they only get about 600 rupees because various deductions, penalties happen. So one of the solutions that we've piloted in Tanzania is really a revolving credit facility. So where we basically pool in a bunch of monies, which goes in and solves the working capital problem of hospital A in the time that the hospital A pays back the second hospital. And so basically together 1,400 balance sheets are a viable, investable option as opposed to one hospital. So that is a solution. It is working in a geography. I don't know if it will work here, but that is a classic case of blended finance trying to solve a problem which, for whatever reason, private markets and public governments have not been able to solve for. The other thing to think about, which is also quite cool, is the fact that each of these hospitals now the private banking folks in Tanzania see this as an opportunity, because once you've taken some form of loan and paid it back, the private banker is waiting and saying, this is a good guy to lend to. And so we are hoping, this is a hope against hope in some cases, but we are hoping that within the next sort of 2 to 3 such transactions, we can actually involve the private banking fraternity in Tanzania to take on the burden of actually offering low-cost working capital solutions to these hospitals. Obviously, because in effect, these loans are guaranteed by the sovereign government, because the national insurance company will pay. They will take their time to pay it, but they'll pay. So I hope that answers vaguely at least some of your questions. Thank you.
Oh, this is just, you could answer him and then I...
No, I just wanted to make a point to you. I think the quality of care and the kind of certification we talk about really in terms of standard operating protocols of care delivery, right, that needs to be really ingrained into the primary care structures as well as secondary care. So if there is a way in which hospitals can be audited for the kind of impact they drive, then their ability to access working capital to sustain their quality of care can be really, say, a positive incentive to provide. Fair point.
Yeah, and hello, hi, I'm Nishan Malhotra. I just wanted to add some of the things which I heard. The young lady there was talking about, how to measure impact. So one of the ways is, of course, positive externalities, because the benefits are greater than cost, and there are a lot of KPIs which you can do that. So that was one thought I wanted to know. Have you thought with, it varies from different sectors, and I wanted to add to you. You took a brilliant presentation. There's something known as a cataract bond, which happened in America, in Africa, where usually impact bond is more like a derivative structure based on outcomes, but in this particular bond, it's almost 100% principal guarantee. So it's become like almost typically a bond-like structure. So do you think that particular structure will become more useful in India, especially when we go to tier 2 or tier 3 cities, wherein you are almost guaranteed a principal payout over a period of time? Of course, you are not getting an interest payment if you don't reach the outcome, rather than not even getting a principal payment depending on this. So just your thoughts.
Sorry, you had two questions, right? What was the first question?
The first question was that we could use positive externalities for things. That was just a suggestion. And maybe...
and what do you mean by positive externalities? Sorry.
Positive externalities are something which you can't directly measure, but for example, if you quit smoking, you're actually stopping the passive cancer of people. So there is a negative externality. So negative externalities always have got taxation. For example, if cigarette smoking causes problems, that's why you make the cigarette smoker package more expensive. So that is known as taxing the negative externalities, and if you are positive, then you actually subsidize the products. And the other way is also calculating how great that impact measurement could be, is to calculating what positive externalities are. You could have created so many positive externalities. For example, your work could inspire somebody to do much better things. That is one way of looking at it. I'm being very journalistic here. It would be.
So at the level of primary care, you mean that the way in which we can define impact is through the kind of positive externalities that we are creating, whether it is probably if there is a child who can go to actually school because they are not malnourished, and we are promoting...
Precisely, so, and that could create over a period of the sort of earnings over a period of life.
Yeah.
And that could be. So that externalities is huge, and we have never been able to calculate it. Not only in recent times, the negative externalities, people have been able to calculate. For example, 1% of the people who missed out classes created, according to IFC report, I don't know if it's IFC or one of the IMF report, leads to trillions of dollars in loss of earnings over a period of time. So they've calculated the pandemic, how much effect it could have created.
This is very interesting to hear. So I guess a point to note over here is that maybe there is an opportunity to create some kind of a marketplace where if we take a sectoral focus and we define the care continuum from primary all the way to the tertiary, we basically define outcomes, and we sort of codify that with a certain cost associated with this kind of an outcome. And this will standardize the practices as far as interventions are concerned. And I think this needs to be standardized. It needs to be based on best practices, needs to be based on the kind of solutions we are implementing in this kind of context. And that's where I guess maybe a platform like this could be really useful, because we share best practices and case studies, and we really figure out what are the learnings from these studies, and really how to say quantify as well as qualify outcomes. So totally agree on that point. Regarding the second question on the standardization of a results-based bond based on what we have learned in Cameroon, again, I have to admit that I'm more of a service provider, not a blended finance specialist. So therefore, if there are people in this audience who want to take that up and sort of see if that can be mapped to the Indian context would be great. Anybody who wants to take that up? The Cameroon bond is what he's actually referring to. Go ahead.
So again, the short answer is we don't know. We don't know whether the bond in Cameroon can actually be applied here. But one would suggest that there are certain criteria which are similar in terms of our demographics and our financial situation. So theoretically, it is definitely a worthwhile investigation for that to happen. In fact, not just cataract, there are also sustained efforts on preventable blindness, which theoretically also can be solved in similar ways. Not health, but there is something called a rhino bond, which is currently happening in some parts of Africa. Theoretically, that can apply to conservation efforts in Africa as well, but again, these things need to be investigated.
If I can just add to that, just ask one last question to Karthik. You know, the data and the standardization is exactly key, right? So rather than talking about how do we bring constructs, to the Ramraj's point earlier, we're talking about healthcare, early stage enterprises, and we know as VCs that they all face this challenge. They're struggling to raise VC money, and we know why in particular segments. Let's say there's a higher gestation period. They're developing a device, they're developing a drug. So even data from healthcare experts, from the industry, from IBFC, of let's say it takes an average of 5 years to bring a device to market. And you know, so if a company does it for lesser, for 3 years, that's where the incentive is paid. How do we actually move, like in education, you know, a bunch of folks like Dalbert, Dell, and others, all of them, Central Square Foundation, over many years came together and established these sort of rate cards. Earlier, people would argue about that as well, educating 10 girls in Jharkhand versus Rajasthan versus Odisha. It's still not a perfect answer, but if we focus in on the 2 or 3 levers and try to establish some, you know, and the industry agrees that if a diagnostics company is able to do this, you know, 2 years lesser than the average, that qualifies as success. So then the incubators are more likely to fund them, right? And the second piece is contracting. The government of Cameroon or others, or Kenya, Tanzania, are probably more proactive in engaging. So what is it that's preventing our governments from doing that now that they're expressing interest in, and that's also linked to measurement. At Asha, when we did the Pune Pimpri Chinchwad Healthcare SIB, the result, the risk investors want a simple metric, which is NABH accreditation for the facilities built. The outcome funder will want like the healthcare indices of Pune, which is impossible. So then you need some intermediate indicator like footfalls. Footfalls going up in the primaries, so therefore the births can happen there and the secondaries are made available. But who's going to figure that out? It can't be done on a case-by-case bespoke basis. So with all of this rich analysis of healthcare systems, data, and analytical issues, if one can start to then pinpoint what those measurement levers could be, then that is potentially a way that one can start taking some of these conversations forward.
That's really helpful. Yeah.
Hello. Yeah, am I audible? Yeah. So what we do see is that most of the funds either have a huge healthcare focus, and then they do have the domain to invest in those high-risk investments, which Ramraj also pointed out, that that high-risk technological innovations. But what happens when a sector-agnostic LP look at these funds? We actually look at some GPs who are pretty much, investing in across all sectors. That's what our first choice would be, rather than investing in a healthcare-focused fund. And these GPs do not have that ability to kind of evaluate the deals in that high-risk sectors, which Ramraj. So as you say, all these things are available in certain healthcare-focused funds, but when we actually go and invest in a sector-agnostic technological funds, we just see some investments in kind of diagnostics or some of the, what do you say, low-hanging fruits. So I think there is some thought here which I would like to leave it with you. Probably there is need for some kind of rearrangement, because I believe that most of the LPs do have a sector-agnostic pool. Of course, few may have focused healthcare, what is allocation, but majority would have that kind of sector agnostic pool, and that is where we find the difficulty. Having said that, I would say that we have still got some kind of very high, very impact worthy investments. I think COES themselves have invested in Panacea, which is one of the cost-effective, innovative cancer treatment equipment manufacturer, and also we have an investment called MedCots, which actually has pioneered telemedicine in Rajasthan. So that's something which I would leave it. Probably this is something which I think we can discuss over time too. Yeah.
Yeah, no, I think that's a great point. Just want to add on to that. I think we've discussed quite a bit around how innovations, which once they move beyond the seed stage, how those can be supported blended finance. I think Ramraj made a point, and we heard a few others as well. I think an area which we've seen as being quite interesting, but maybe haven't seen so much action there, is basically in service delivery, where the organizations which are engaged in service delivery now want to essentially move on to a slightly riskier segment. So, for example, when you think about providing high quality tertiary care or multi-specialty care alongside highways, for example, in India, and then where you know that the uncertainty is much higher, but there's a substantial need, and we know that at this point of time these are not being served. The models are well understood. However, the demographic ability to pay, the kind of people which might turn up, the government of course becomes another stakeholder. I think there's a lot of challenges around the demographic, the kind of market, and uncertainty around the kind of market that people are getting into. And I think that's an interesting one where we've often seen there being some thought being put in, though again we haven't seen a lot happening. Where I think there has been some progress is governments really thinking about it. And if you think about public finance as being the third leg of blended finance, and governments actually utilizing some kind of PPP models and then blending in that way to actually support some of these, and that has been another interesting sort of sector or area. And just to add to that, I think the maybe slightly more fundamental point, which is if we are eventually saying that blended finance has to sort of help balance out in some ways the risk return mismatch that investors find challenging, then I think it also becomes really important to evaluate where is it that this kind of finance does not compete with what is already happening, right? It shouldn't be, I think one of the big challenges that we notice often with blended finance is that those blended finance providers are competing with commercial finance providers. And then, that doesn't make sense because it is not really allowing for the creation of new capital. So therefore, even in some of these more traditional slightly it's not pure innovation, but there might be business model innovation. There might be extension of services, etc., to riskier segments, demographics. This could be a pretty interesting area to look at. So just want to add that.
Thanks, Tushar. Anyone else? And should we break now, Pragya, for this thing? Okay. Yeah, please go ahead. Yeah.
Hi, I'm Bhavya. I'm from Save the Children. So just a thought to share. I was just thinking that, from impact perspective and specifically coming from an NGO, non-profit, organization, I think there needs to be a right kind of alignment between how you choose an intervention for a specific instrument. And we specifically talk about the blended finance, because at the end of it, the impact that you want to achieve will define how you design your outcomes right from the beginning, and be it any blended finance instrument. So I think that stands across it, and so it becomes very relevant for us also as a service provider implementing organization to thought through that strategy, that the outcomes that you design will also depend on the intervention and the context and the problem that you need to define. So whether your intervention is impact driven or instrument driven, that would affect a lot on how you go ahead in measuring your impact. Yeah.
No doubt. So what we are going to do is, I think that's been a good discussion after, so we are going to have a quick break now. And post the break, we have, I think, a bunch of case studies. There are a lot of transactions happening, but surprisingly, when we talk to a lot of people, Many people are not aware that a lot of these is happening in different fashions. And I think one of the whole agendas of IBFC is just to showcase that this is not one more pay for performance, some deal happening once in a couple of years kind of thing. There's actually a fairly decent number of transactions happening. IP Global has been doing, COIS has been doing, several other people have been doing. They may not use the word blended finance. They just kind of do something and what does it matter what you call it? But effectively, so I thought we'll do a session where some of the people will present some of the case studies. So that's what's after the break. And then we also wanted to get in some inputs from some of the philanthropists, people who have been managing larger money from philanthropies in blended finance. What has been their experience? And we have some of the people in the room who would want to share some of their thoughts. Because eventually, commercial funders will always come. Hopefully, if the risk return works. But really, if I may say, the challenging part is to be able to get grant providers who are willing to take this kind of, if I may say, ambiguity in terms of what the TOC or the theory of change is and where are they and where they want to reach. So I think we'll have some conversation in terms of what have been their experiences and what is it that we can do to get even more people, philanthropists and other people to participate. That's really what's there after the break. So Pragya, this is now 4:35. What time should we be back? Yeah, maybe 4:50 we'll be back. And then we will hear quickly on some case studies and, then we'll try and get some of the other people to participate. So that's really what is up there now for the rest of the evening. We are, as you are aware, running a bit late and we still, obviously we can't finish, as per the time, but we'll try and kind of keep it snappy over the next 45 minutes or so. So thank you all. Do join us for coffee and snacks outside. Thank you. Which are really investing in far more scalable and well-established businesses. So I think we are now going to talk about two things. So I think the first one, which we are going to, we're just going to flip it over. I think the first part is really to look at philanthropic capital and how it can support and drive financing innovation. Because as we all know, commercial finance, I would not say is freely available, but with an appropriate structuring of risk and return, commercial capital could be made available. But the availability of good quality grants or good quality philanthropic capital, loosely speaking, with the right kind of structure is really the major fly in the ointment. And we thought that it may be useful for us to sort of just share some thoughts on how some of the people from the philanthropic world or people who are managing philanthropic money think about something like this. And that's really what we are going to do over the next, maybe 15-20 minutes. And then we'll get into some of the case studies, which will really showcase how people are actually using blended finance in healthcare. So I think on the philanthropic side, we have Neeta from ACT Grants. I'm sure you're familiar with ACT Grants. They've been doing a lot of work in the health space, over the last several years. They have not done blended finance transactions at this point in time. And I don't think the idea is also for them to share necessarily how they think about blended finance. It's really more about how do they look at this concept and do they think that this really makes sense or it doesn't make sense? And how do their sort of principles think about something like this? I think is really what she's going to speak about. We also have Karthik from Desai and Associates, who's actually working today on a very interesting structure on a pay for performance in, if I may say, the health, food, nutrition space, but also in his past avatar at Asha Impact, which was really a sort of an investment platform for family offices and high net worth individuals. And how does he see this part of the market? So we'd like to hear from both of them in terms of their thoughts and experiences. And after that, we'll open it up if any other people have any perspectives. And then we'll go to the last section, which is really on the case study. So over to you, Neeta. Do you have a mic?
Sure.
Yeah, okay, great. Thank you.
Thank you. Thank you so much. I apologize. I have a bad throat. I'm Neeta. I lead the healthcare vertical for ACT Grants. I'll begin with a little bit of context about who ACT is and how ACT came together. So in March 2020, a group of venture capitalists got together and spontaneously formed a fund to act against COVID. So they put together their personal funds, their some funds from the CSR corpus of their own respective VC firms, and also got some founders engaged. So over a couple of weeks, this tribe grew, and I think in about a couple of months' time, also managed to get support from the traditional traditional philanthropic sources as well, and put together an initial grant corpus of around 100 crore rupees to be deployed into various initiatives in COVID response. So I think the first couple of years of our existence, that is 2020 and 2021, we've been focused only on COVID. So year one, we funded a bunch of startups that were working in multiple areas of COVID response, working very closely with various state governments, COVID task forces. During this journey, we were able to pilot successfully several innovations, some of which got adopted into the government system, most notably ones like Cloud Physician, Criti ICU, Dozy, and Cardiac CDL, Cardiac Design Labs. In 2021, we also did a lot of relief-like work where we delivered oxygen concentrators, set up PSA oxygen generation plants, set up vaccination camps, and so on. So 2022 has really been our first year of looking at health system strengthening or healthcare beyond COVID. What ACT really taught us is that ACT was able to mobilize resources from the VC and startup industry, the traditional VC and startup industry, in a manner that was not done before. So at our peak, we had around 300 volunteers engaged, running various parts of the initiatives in COVID. We also got pro bono support from a few marquee consulting firms like BCG, McKinsey, A.T. Kearney as well, to help us with our program management. In 2022, which is our year of beyond COVID, we've been looking at funding various digital medtech solutions. Our portfolio is now 12 organizations strong. Notably, we have been the earliest as well as some of the biggest funders of a couple of digital public goods. One is the Swasth Alliance, which is building the healthcare exchange platform with the NHA. Another one is a care module, which is sort of running the tech behind the 10-bed ICU project, which is today there in over 10 states. Right. So how we look at sort of scaling these innovations, and please note that we are the new kid on the block and we are learning, but our thesis really is to as we go forward, invest not just in the solutions but also in the environment where these innovations can thrive. So our focus very much from now on is to create that germane environment. And we've started working, for example, with the government in a more deliberate manner. We are in advanced conversations with working with the state government to enable their hub and spoke cancer care network with a digital pathology solution, which we funded in late December. We've launched an implementers network of NGOs, which is today 15 NGOs which run run hospitals and clinics in low resource settings. And here the focus for us is to create real world evidence, taking these technologies that we have supported and continue to support, and really invest in processes and people. So really invest in the workflows, invest in trainings, create the real world evidence, also arrive at the commercial validation post the pilot is over. So I mean, in short, we want to really work on all the forces on the demand side. So we, like I said, we believe that supply side, like working on the supply side is not enough. So we definitely want to find out if there are interventions that we can do to support innovations as they access the private network. So somebody had mentioned about how that is increasingly difficult, and early conversations with our portfolio companies tell us that working capital is a huge problem, and that is definitely something that we want to explore if there are ways that we can play a role there. And really another untapped potential, I think, for ACT is really a little bit of our soft power, right? The access that we have to the traditional VC community, and our board consists of members from that community, like senior VC partners and so on. Can we do a little bit of a knowledge exchange between the science-based innovations happening in our country? I mean, I don't want to use the word mentorship because it's a little patronizing, but can you, in some sense, mentor the VCs, right? Because if you look at the COVID example, a large part of the healthcare sort of pie during COVID was diagnostics. So there is money to be made in diagnostics, but there aren't probably enough people who understand the indigenous diagnostic market very well. So can we do that knowledge exchange, as well as maybe have the VCs and the startups who have scaled share their learnings on go-to-market, commercialization, and so on. So this is really an untapped potential that we are yet to explore and act, but we're very excited about this.
Yeah, thanks for that. Maybe a couple of questions before we move on. So have you, if at all, evaluated or considered the space of this blended finance, or it's not something that is still on the table, or was it on the table and now off the? I mean, I'm asking a very broad question, and I don't want to put you on the spot in any fashion, but I'm just trying to understand, because you know, some people do believe that there is enough and more space in. So, you know, one school of thought can be, let's try to solve for the complexity on the execution side and not bring complexity on the financing. Keep financing simple and get the complexity on the execution side, which is on the ground. Some other people feel, no, this is a, you know, a very different way. So what's been the conversation within the organization?
So we haven't approached it from a place of let's try innovative instruments.
Right.
But in our portfolio companies, for example, there are a bunch of medical devices companies who have a very high upfront capex. So we've been really pushing them to try a rental model, right? So there the working capital problem really comes in, because hospitals are not willing to fund that, basically the cost of credit, right? So. So that is how it organically came about, and we are, you know, in the process of, we really want to support them if there is something, if there is a role for us to play.
No, I think that's good, and maybe you know, when hopefully over the next few weeks we set up these you know, deal spotlight, it will be good for you to share. And when we say deal, it doesn't, you know, this is not a syndication conversation. This is more of a conversation around what people are doing. Be useful for others to know maybe some of the kind of things that you're thinking about. How are you thinking about this upfront capex? What kind of structures you may be looking at? Anyway, you have a lot of people who are from the financing side on your board. I'm sure they'll come up with some interesting ideas, which loosely put could be blended in some fashion, but you know, it's just that maybe that terminology is not something that one uses. So thanks, you know, Neeta, for that. Maybe Karthik, some thoughts from you, you know, given your considerable experience, particularly in working with a lot of large philanthropies as we speak, as well as in your past role at Ashaya.
Sure. No, thank you so much. So I think getting philanthropy into this space is obviously the most important thing. We've seen that from outcome funding being the key gap. Just brief background. So Asha Impact was a multi-family office. It's for 10 very well-known UHNIs. It was set up 8 years ago, and their intention was both to make for-profit impact investments and all other things. So HNIs have this bimodal approach often, that they say let the profit be made on one side and let philanthropy be on the other side. So by definition, blending is tricky and complex for them. I'll just quickly walk you through the 3 or 4 issues that come up. One is they say, is this money coming from my commercial bucket or my philanthropic bucket? And what does that mean? We're saying, look, it's returnable capital. So earlier you were giving a grant, now you're getting the money back. It's pricing and all of those things are still important to them versus inflation and things like that. The tenor versus an institutional investor, they'll want that money back quicker. And the tax aspect. So it's much more on those aspects. Conversely, the impact definition is more thematic. It doesn't have to be perfectly metricized. They understand that these are the big, large problems of India. So the key issue becomes about scalability. So let's say there's a working capital transaction which Kois was working on, which I took to these HNIs for my contractors. And they said, first is downside risk. We lose our money because this is a risky segment. No, you won't, because there's a guarantee from a foundation. Okay, very good. So it's de-risked. So the real question then becomes about scalability. They're saying, what's going to happen? It's only a $100,000 thing. The problem is worth millions. Have you spoken to DLF and others? Once this pilot is done, will they incorporate it? Why should, as an HNI, get involved? The time, the cost, and the money is too much versus these liquid transactions. So these are sophisticated HNIs, right? Who are actually looking at blended finance, who are educated about it, who are curious about it, who have that impact lens. Now what I'm doing is, I have a boutique research advisory advocacy firm, just looking at these issues and focusing, working with NGOs, large NGOs, as largest. So the idea there is straightforward, that many of these NGOs have existing funding sources, right? As a typical investment banker, you don't have to go there and introduce them to anybody. They know every single large funder in India. But did you know, at the expense of sharing too much, that the average ticket size is less than 1 crore? So every blue chip corporate gives to them 1 crore, right? Which is nothing. And HNIs give. So what's the issue here? Many of you are familiar with Akshay Patra, right? Midday meal program, they run kitchens and all of that. But they're constrained. Everyone wants to give them CapEx to build a new center, to have their name on it. So what are the 5 things that they need? They need to move towards an endowment model. They're saying, instead of giving me 100 rupees for 10 kids today, can you give me 100 rupees for 1 kid over 10 years? That's a completely different way of thinking. The second is guarantee structures to enable debt. Someone mentioned this earlier. NGOs have large working capital. Of their 750 crore budget, half is payments from governments. They're 9 months delayed. So you can do the maths. IndusInd Bank and other banks would lend to them, provided that there's a guarantee. Who's going to give that guarantee? The HNI should give it. It can't just keep coming from foreign sources. So that's the advocacy that we do. Saying, look, HNIs is a room for you to give like 10 crores and 100 crore of debt will come. So that's the second one. Third is results-based financing on environment. Bunch of infrastructure in their plants, from biogas to electric vehicles to whatnot. So a donor can give that, capture the environmental metrics. It's not happening right now. It's actually revenues. Imagine these assets are used to feed the children in the morning, but in the afternoon it could be a chargeable model, feeding meals to people on a paid basis. Then you have revenues coming in. So, really, really interesting stuff. And the fifth is local capacity building for exits. So there's many, many ways. I'm just giving you a case study of one particular NGO who can actually go and engage with HNIs who are very familiar with it, who want to support it. So now it's no longer just build a center in Jorhat, with my name on it, but these other ways which can be highly catalytic. So there's a lot of philanthropic interest, but the issues around regulation and these very precise issues are, in a way, now becoming more important than just the general market building, because there is more and more awareness to it. So these are my 2 main submissions.
Got it. Thanks, Karthik. Maybe others in the room, and from a philanthropic perspective, maybe Biswa from IKEA, maybe some perspective. You guys have also been doing, a lot of. In fact, coincidentally, Biswa and I have spoken so many times, but I've never met him physically. The first time I'm actually just seeing across the room and seeing that familiar face. So maybe Biswa from IKEA. Anyone else here from Give India also? Huh? Yeah, Narayan, maybe, happy to hear some of your thoughts also, because, you guys also work with a lot of people in the market. So possibly some thoughts from both of your sides, and then anyone else, maybe Shama, you also work with Tata Trust and a bunch of other people what are the kind, and you guys do a lot of innovative stuff in terms of using a variety of structures. So maybe some thought from all of you guys. Over to you, Biswa.
Sure, thank you. I think it's been very, very enriching as a discussion. But one of the things that really encouraged us to come for this workshop was we were very intrigued to understand what kind of an umbrella structure brings all three forms of capital, like debt, equities, and grants together to support health sector, right? So we are active in different other sectors. So it's a little bit of a sectoral agnostic kind of an approach that we are having. But we'd definitely love to learn from the practices happening in this sector to be replicated probably in the climate or energy sector wherein we are active, or in the agriculture sector that we are working on. So so as you rightly pointed out, like, Karthik, what you said, like, one of the pain points for the philanthropic organizations is navigating the regulatory complexities, right? So there isn't a kind of dearth of interest into it, because there is an increasing recognition within the larger kind of board members and the senior leadership within the philanthropic organization that, you really need to bring in the private sector capital, right? And most of these philanthropists are from the private sector. Let's, appreciate that fact as well, because, that line between pure philanthropy and, blending philanthropic money to catalyze private sector capital is gaining traction, right? So, and that's more and more people are realizing that's a way of forward. Like, but for many of them, they are a little bit like, on a very, very cautious kind of a side, saying that, they don't want to take the regulatory kind of risk associated with it. And we know it's a complex scenario for the Indian markets. We have this FCRA with the grant money, and it can go to a private for-profit institutions or not. That has been, and whether equities can be done. Yeah. We understand, like, patient capital is required, long-term capital is required, concessional money is required. These are all the needs of the sector that we are talking about. And it's sector agnostic, if we take in that sense. But yes, whether philanthropic money can go for a kind of equity investment in a very early stage enterprise or not, we are stuck there, right? Or we can really provide as simple as a grant money to a kind of for-profit entity. We are unsure about that. So what the regulation looks like, what kind of vehicles are appropriate. So we don't have that bandwidth, and really would like to support from IIC-like institutions, or, there are a lot of thinkers around how to go about it.
Yeah, thank you. Maybe Narayan, from your side. One second. Let me just. No, that's okay.
Yeah, thanks. We as Give India, we work with corporates and foundations on the CSR giving. One of the reasons for me being here is to also get a sense of what is the kind of traction which we're seeing. Most of the corporates that we've had conversation with around the blended finances, one of is very similar to what Biswa said, right? So the first thing is that regulations are a bit hazy. Typically, they work on a one-year cycle. Even for companies who are willing to look at ongoing projects, they are still unsure. They're not very sure whether they want to be sitting on the fence from a regulatory point of view. And the others has been that there's a lot of interest, but in terms of traction, they still are at a place where you want to see what's happening around. We've had discussions in the past. There still is a feeling that the market is a bit early for some of them. But I guess one of the good things that you also mentioned is that it's not in 1 and 2 years. There's a lot more happening, which is sort of great news. And the intent is to take back the learnings and understand what others are doing. Got it. And circle back and see what's happening there. So there is intent and interest. I think there's a little bit more traction which is required, number of transactions which is happening, and I think we'll see action over here.
Yeah, I think maybe there is need for us to also in a nice way, showcase some of these transactions, because there is a belief that something is happening, but actually there are a lot of transactions happening. And possibly that may actually trigger a lot of thinking in people's minds. And every one of the structures is not this 1 year CSR issue of, carry forward kind of. There are simpler structures that people have been working on. And I think one of the thoughts that we have been having from IIC is maybe kind of building a series of case studies around just transactions which have happened. We all know about Educate Girls, and maybe we know a couple of other transactions here or there. But there are several other kind of transactions which have happened, which haven't really seen, or I mean, I'm not saying that they obviously have seen the light of day, but I don't think we've made a song and dance about just saying these are all the transactions that have happened. So it may be useful for us. Quality Impact Board, they've been doing some events and so on and so forth. I think there is a need for us to do a lot more, just show and tell kind of thing, which is something which is very valuable. But I think thank you for your inputs. Any other sort of pointers from others before we move to the
just another small point. Establish the fact that it's fine, it's kosher, and we still have companies have taken it. But I think there's still more, a little bit.
Yeah. Because we're also going to do a fairly detailed deep dive with Maya of Trilegal later this month around structuring legal challenges in sort of blended finance. He's worked on extensively on multiple transactions, and they've found loosely put roundabout solutions. But I think in the longer run, I think we're just discussing, the real way to do this is through the social venture fund route of SEBI. The social venture fund original mission and mandate is to be able to do this. It is just that I think as a community, we have not invested time and effort with SEBI and other people to try and to a limited extent at least structure the SVF in a manner that it is amenable to convenient blending, okay? Because right now what you're trying to do is just trying to go around in some way but still do the transaction. But hopefully over a period of time, if we are able to showcase to SEBI why something like this is valuable and important, particularly in the context of the social stock exchange, because ideally we should see more blending on the social stock exchange, especially given that it has got the regulatory kind of blessing. It's far easier sell to a subcommittee of any board to say that, boss, this is a SEBI blessed transaction, rather than to say, oh, we are going around it like this, and it just becomes a very difficult sell. So that's maybe a limited point. Someone else had a couple of thoughts, maybe Shama, and before we move on to someone else, please.
Can I come in? Yeah, thank you.
So maybe you can just introduce yourself. So by the way, that was Biswarup from IKEA, Narayan, right? From Give India. Sorry, sir, please.
I'm Dr. Antaryami Das. I'm from Save the Children. And my experience, for last 6 years in this organization is that we get a lot of funding from corporate. And, some of the corporates that they are, funding us a, huge amount of money. And for the last 5-6 years from a single corporation, that could have been a good blended financing if you look at, from the, quantum, perspective, the total amount of funding that they have, given us. But the moment we speak about blended financing, and we have had, series of dialogue with many potential outcome pair, they say that the overall, the transaction cost and the overall, per child cost, or maybe the, unit cost per beneficiaries increases by several fold, through this mechanism. So how do you reconcile that, and they understand that the, impact that you will be showing is more or less similar than, what you are doing in a project mode. So this is a challenge that we face in our day-to-day, conversation. If you can throw some more light.
Which is, sir, a reality. The fundamental problem, and this is not given my deep expertise on the subject, it is really the subscale nature of some of the transactions. When you're doing a very small transaction, the fixed cost of the transaction naturally have to get amortized over that smaller base. Unless, if the same transaction was 4 times as big, or you could raise that kind of funding, suddenly everything would look like 1/4 of what it was, making it a lot more relevant and a lot more sort of useful. So amongst many other things, there is one space which is to, if I may say, declutter and simplify transactions, which is one need. But the other big need also is if more funding is available and larger scale funding is available, instead of doing maybe a 50 or a 75 or a 100 CR deal, if someone could do a 300-400 CR deal, I'm just randomly throwing numbers. I'm sure there are huge challenges in doing something like that. You could do that. Suddenly the costs look very, very different. And personally, I have in my own earlier career in the financial market seen, when some new things started, it looked very subpar, subscale, very complex. But suddenly when it grew, you see a lot of simplification, you see a lot of standardization, and you see costs dropping very, very rapidly. Cost of acquisition, cost of financing, cost of other investment banking, all of that. Sorry, Amit, you had some points. I think this is the last point, and then Shama, maybe quickly, couple of you guys, one minute, and then we need to go to the case studies because we also do need to wrap up. Yeah.
Sure. So one small point to you, sir, and one point that I wanted to point out. So the largest bond that we've structured so far is a $27 million bond. And obviously, hence, the cost per beneficiary reduces significantly. Because you're trying to place one product, I think we have only 2 donors on the $27 million bond. So which means that we are not looking for people who have the ability to write a $1 million check. We are looking for people who have the ability to write $10+ million checks. So that was one. Second, I think the other way to maybe think about this, and I've had briefly mentioned this to you, Ramraj, is that we are focusing a lot of our efforts today on generating the demand for blended finance transactions.
Got it.
Very few of our efforts are focused on generating the supply. So, I mean, Save the Children is one of the non-profits in this room. I think one of the other things we need to put some effort to is getting a lot of the larger non-profits to themselves start to think about what blended finance could mean. This is a point that Bhavya had also raised a little earlier. And hence, they themselves convince their donors to bring more blended finance transactions to the market. We don't need to do the heavy lifting of raising the money. The non-profits are more than capable to raise money for some of these transactions.
Got it. What we may need to do though, Amit, is create the playbooks to enable people to come and think about it at maybe the next 1 or 2 levels of granularity beyond just saying this is how blended finance works. We may have to create those playbooks which people can just, may not be off the shelf kind of thing, but at least can they go 30-40% there. Quickly, Apoor and Shama, some points before we move on to the case studies.
Yeah, a couple of points really quickly. I think on the non-profit side and building the supply side, definitely important, but I think we should always keep that what is the development challenge and what is the financing challenge we are trying to solve, right? Let's also not, say blended finance is a fit for all. So just keeping that nuance in mind. I think secondly, what Ramraj also touched upon, and you also talked about the cost of transactions. I think we are starting to move a lot more towards big platform approaches where you're, having multi-stakeholder platforms with large sums of money coming in where you're able to spread out this cost and are also able to use it flexibly almost to tackle a specific challenge through different types of structures. And SAMRIDH is a great example of that, right? Under one facility, they've been able to do technical assistance, which the enterprises needed. They've been able to structure low-cost debt. They've been able to structure guarantees to bring lenders in. So, more and more such kind of platform approaches could help move the needle. And last point around regulations, I think great conversation on all 3 pieces there, CSR, FCRA and HNI related regulation, and now we are seeing a lot of examples of how all these types of capital are indeed being used for different aspects in blended finance. So, for example, CSR, we've been able to bring a lot of players in to do returnable grants through CSR. There are live examples and many CSR donors have done it. So I think showcasing some of that. There's also been a lot of outcome funding that's come through CSR now in the last 2 or 3 instruments that have happened. I think Quality Education Day, there was a Haryana Day, and now with Back to School's Outcome Fund also, we are seeing more and more CSR finding those ways to legally do it. FCRA, again, I think Biswa, your organization is a great example of how you've innovatively used grants to de-risk through our partnership on a credit guarantee. Dell does so many credit guarantee. So there are examples of, using even FCRA money more catalytically. We are also exploring, doing guarantees in some way or the other. And lastly, HNI, Karthik, again, we don't have as much experience working with that space, but our understanding has always been that's one, at least the domestic HNIs, they're not as bound by these two regulations, right? And will have a lot more flexibility in how you deploy their capital. So can we find ways to engage with them more and see how, we can create those pathways for them and really, bring more capital to the space?
Okay. Yeah, I'll just take quick 2 examples of how we work. So we look at financing options which are stage appropriate for the startups and the innovations we work with. So in early stage, a grant works better than you go to equity when they come to market. And what we have experimented with, and with IKEA Foundation, there's a initiative called Sustain Plus, not exactly healthcare, but that works towards clean energy and climate solutions, is to unlock the paying segment for the first 100 to 500 customers. So the nature of this financing tool was still grant, because we were working with it for the first time, but we are increasingly seeing a need for it to turn into a debt solution rather than a grant solution. Because some way where we are talking about market creation, if you make your first customers used to getting it for free, the next 100 don't want to pay for it.
Got it. Got it. Thank you, Shama. I think very useful point from everyone. We're just going to now get to the last section around some of the case studies. We hand over to Archish from IP to take it conversation forward.
Thanks, Ramraj. So a lot of interesting discussions has happened over since last half an hour, I would say. Previously, it was more like a monologue from some of the speakers. So it won't be a monologue session from my end, so please feel free to ask any question in between. So, yeah. Pragya, you'll have to do it. Okay. So, as my friends, Dr. Manjunath mentioned about various opportunities and challenges in the healthcare space, primarily various subsegments like medical devices, primary healthcare, diagnostics, and so on, right? So some of these challenges require a different approach altogether. So there is a need for innovative technologies to come in so that India can leapfrog from where it is right now. However, so many of these solutions have come up recently thanks to pandemics, right? So for example, there were only 20 RT-PCR labs in the country. There are now 2,500 plus RT-PCR labs now, okay? And thanks to the government of India, institutions like BIRAC or Atal Incubation Center, which have provided the much needed initial capital to seed some of these solutions. However, most of these entities have been able to scale from 0 to 1. They have created a fantastic product, but where they lack is the access to affordable capital when they want to scale from 1 to 100, right? So there are various reasons why these entities have not been able to raise the required amount of commercial capital. So we have got people like Health Quad, British High Commission, who are basically putting in equity, but most of the capital is chasing only few entities right now where they can maximize the returns. So entities like for-profit entities, but with social mindset, they struggle a lot when it comes to, say, raising capital. So one of the primary reason is the high perceived financial risk coupled with low return profile of these entities. The second is the information symmetry. So which is very different from what innovators think, from what financial institutions like banks and NBFCs think, or what equity investors think. So the issue is many of these typical traditional financial institutions, they don't understand the technology behind a particular model. So they find difficult to fund that kind of an entity. So there is a lot of capacity building which needs to be done for the financial institutions. As Neeta was mentioning, their board is now asking them if they can train VCs to understand some of these technologies better. The third one is from the entity's perspective. So many of these innovators have created very good product. They understand the product very well. They have perfected it. But where they lack is the market strategy. So there is, so how the product should be priced. Can this be a rental model, or should it requires a upfront investment from, say, from a hospital. So some of these things they are not able to understand that much. So what we did was we followed a platform level approach where we brought in the technical and business advisory support by bringing in right kind of people in the team. So SAMRIDH, talking about SAMRIDH, so it's a very different kind of facility where we have got public health experts, medical innovation experts, the financing experts, as well as the people who have scaled businesses as well. So in the form of advisors. So a whole ecosystem approach is something we have been following. And I think this is what is required. We really want to change the healthcare ecosystem in India. So a collaborative strategy where the public funders, the government, the philanthropic capital, the equity investors, of course, and the typical commercial institutions like banks and NBFCs, if everyone can come together, we can actually achieve the Sustainable Development Goal 3 much faster than anticipated. Next slide, please. So I'll talk about a little bit about SAMRIDH footprint. Dr. Manjunath mentioned about WHO Health Systems Framework, how WHO defines the overall approach towards creating better health system. So we also try to follow similar kind of an approach where we have funded entities which are in service delivery. To give an example, like Karma Healthcare, Seva Mob, Sukda Hospital. Some of these entities are providing and service delivery to the beneficiaries. When it comes to, say, medical products, we have funded around 8 to 10 entities. These are the devices which are meant for the tier 2, 3, 4 towns. These are not the typical kind of devices which you generally find from, say, GE Healthcare or Philips. So they are very low cost devices and work very well in low resource settings. For example, Jeevtronics has created this dual powered battery operated defibrillator. So where there is no electric supply, it can work there as well. Then healthcare workforce. Healthcare workforce is a big problem across subsegments. So we have funded entities like AAA Healthcare. In fact, Wipro also we funded during COVID times when there was a dearth of the healthcare. There is a lot of upskilling which was required at that point of time. Skilltree, which is creating a very innovative model of nano entrepreneurs where 5 to 6 nano entrepreneurs are coming together and setting up a telemedicine center or telehealth center. Healthcare financing, we have brought in various kind of financial institutions and trying to create portfolio level structures which can create high impact and bring in leverage as well. So many of these entities which are, say, currently operating in tier 1 towns, but they have the potential and to scale up in the tier 2, 3 and the rural areas. Can we incentivize them in some way or the other? Because many of these entities have raised substantial amount of equity capital. So their investors want them to focus only on tier 1 towns. Is there a mechanism to incentivize them to go to the rural areas? So this is what we have been trying to do here. Then healthcare information system, as Dr. Manjunath mentioned, government has now renewed focus on how we can use information in a better way for effective decision making. So we have funded few entities which are working in this direction. For the overall leadership and governance of the facility, we need to bring in right kind of entities. So we have been able to collaborate with the leading government entities like National Health Authority, Principal Scientific Advisors, Government of India Office, Niti Aayog, and so on. So there is a lot of advocacy which has happened over last 2 years. As Karthik also mentioned, Mr. Kant talking about blended finance in international forums, talking about how credit guarantees can be used effectively. So this is something we have been trying to do. We also have got National Credit Guarantee Scheme to fund some of the entities in the portfolio. However, so while there are certain government guarantee schemes which are available, however, the innovators or the startups don't know about it, or the financial institutions are not utilizing those guarantee schemes in a better way. So a focused approach is required, wherein we can bring in all these entities together, and that can be transformative in nature. Next slide. So I'll discuss about one case study, but before that, I would like to give you a overall idea about SAMRIDH's portfolio. So over last 2 years, we have funded more than 60 plus solutions pan-India. Out of these 60 plus, 38 are directly funded and 22 are funded through our portfolio structures, where we have provided some sort of incentive mechanism in the form of interest subvention for expanding into tier 3-4 towns, or a viability gap funding at a portfolio level approach, where opening a center in tier 2 town or in a rural town is the initial cost is high, or there are initial losses. So if you will see, out of these 60 solutions, many of these innovations have been tried for the first time. So many of the philanthropic funders right now, they are not sure how they can fund for-profit enterprise, whether it will bring the required amount of impact or not. So I'll take an example of the case study in the later slides. Can you go to the next slide? So here also some of the innovations, like we have tried to fund remote ICU monitoring platforms, AI-based entities. During COVID times, we also funded some oxygen generation plants and so on. Next slide. So in last 2 years, we have been able to create an impact. So we have been able to improve 1,000 plus healthcare facilities directly and indirectly through these enterprises, reached out to 25 million beneficiaries indirectly and around 10 million beneficiaries directly, upskilled 25,000 healthcare professionals. So if you will see on the right side, a portfolio construct, we have used variety of instruments, and so instrument, seeing what kind of instrument will fit best. It is all to do with the financial pain points of an entity or the sub-segment within healthcare space. Say, for example, returnable grants, which are essentially zero interest loans. We have been able to use these returnable grants in where there was a sustainable business model available. The entity may be very risky for a financial institution, but they may have the capability to pay back debt, but may not be adequate, generating adequate returns.
Ashish, what is RBF here?
So result-based financing. So result-based financing is outcome-based financing only, but our approach towards result-based financing has been specifically for two things. If the result-based financing is leading to market expansion. So we have funded a lot of not-for-profits under this approach. So there is an entity which, for example, Save the Children, if they are working in a particular geography, and the model can be scaled up in other geographies as well. So we have funded some of the entities in the healthcare space where we found the model can be replicated to a particular geography, but we wanted to fund only if the entity can generate the expected outcomes. So there we try to use result-based financing. There are other ways in which we have used result-based financing, primarily in the situations where we are funding, say, mitigating the risk for the private capital to come in, which further leads to debt or equity raise. We have also done partial risk guarantees or first loss guarantees to bring in direct commercial capital from the financial institutions. Next slide. Now, I'll touch base upon a case study. This is one of the blended finance solution. Many of the people may disagree that it is not blended finance because there is no hard and fast rules for blended finance, I would say. As long as it is leading to more impact, leverage, as well as returns for the private capital, we generally classify it as blended finance. So, Biswa, you mentioned, can there be an umbrella approach where debt, equity, and grants can come together, right? So this is one such example. I'll explain it. So this is one of the tele-ICU hub and spoke model, an entity called as Critical Care Hope. They created this particular model during COVID times when there was a need to increase the number of ICU beds or This cannot be done overnight. So the entity came up with a very innovative model. So the problem statement was that in 2020 there were only 95,000 ICU beds for a population of more than 130 crores, and the specialized doctors, primarily intensivists, they were very less in numbers who can handle the critical care ill patients. So there were only 5,000 intensivists in the country and 95,000 ICU beds. So what this entity did was they created a hub and spoke model. So generally a specialized doctor can manage only 10 to 12 ICU beds at any point of time. What they did was they created this indigenous equipment and created spoke hospitals. So through the technology, a specialized doctor was able to manage around 60 to 80 patients at one point of time through a centralized command center. This entity was operating around 18 cost-effective tele-ICUs across Rajasthan and Uttar Pradesh. So one of the solution focus is also that it provides 24/7 technical assistance to the critical care experts there in these spokes, deploy automated warnings and diagnostic assistance as well to provide high-quality care.
So
and end-to-end manpower support.
If I may just stop you. So in this structure, what is the nature of the risk that you financed and what was the nature of the structure? It's not very clear here.
Yeah, I'll get into it. If you will see from the impact point of view, so during COVID times, as we have seen, during the emergency situation, a lot of hospitals there in the tier 2 or tier 3 towns, they say that they refer generally critical ill patient to a hospital which may be there in, say, tier 1 town, say Medanta. If we are talking about, say, a tier 2 institution like, say, Moradabad or Bareilly. So what happens is that it takes around 4 to 6 hours for the patient to reach there. And study has shown that more than like 15 to 20% patients, they don't make it to the hospital, right? So as far as expected impact is concerned, this was leading to a reduction of the mortality rate by at least 10%. So this is something which we found can be supported through philanthropic capital. So Ramraj mentioned what were the challenges being faced by the organization. The initial setup costs are still high because there is a requirement of indigenous equipment to be placed in the spoke center. High operational costs during the initial period till the entity reaches optimum utilization of these resources. There is training required at the spoke hospital. So either the manpower can be deployed from the command center to the spoke or they have to train. So there is initial high training cost. And since there was the time to break even is at least 12 months or so. So there is high credit risk when it comes to funding these equipments through debt. So there were some of the challenges that entity was facing. So while entity may have done it on their own, but it would have taken at least 3 to 4 years to expand without the philanthropic capital coming in. Can you go to next slide? So how we approached this particular problem was we tried to see if we can bring in a financial institution like HDFC Bank, which can give the loan for the capex part of it. So with our support of viability gap funding, or I would say result-based financing for market expansion, so the entity was expanding into 5 new states with the similar model which they have created, opening 40 plus ICU centers. So with our support of around 428K US dollars, around 3 crores in INR terms, we were able to get in a private capital from a bank to the tune of around 5 crores directly. And when I say indirect leverage, that will be much beyond, because the entity will be able to showcase this particular model and can expand multiple folds because the entity will be more sustainable going forward. They will not be loss making. They will have low reliance on the equity providers. So to your point, Viswa, so the entity raised equity first from Somerset. So this entity is the subsidiary of Apex Hospitals, which is a multi-speciality hospital in Rajasthan, having 6 more spokes hospital in and around Rajasthan in the tier 3 towns. SAMRIDH supported this particular entity through a viability gap funding, and we were able to, with our support, the entity was able to set up 12 new ICUs within the next 6 months. So some of the key achievements that have happened since last 6 months now is that entity has been able to raise debt capital. They have been able to optimize the cost and resources. So to operate a particular ICU bed, the cost to operate this kind of an ICU bed in this environment, hub and spoke model, it is 45% cheaper than in a normal scenario. So this is led to the cost savings and reduce the out-of-pocket expenses for the end beneficiary, who is paying much lesser now compared to a traditional hospital in tier 1 city.
So Archish, we have just about a minute left.
Yeah, so I'll just close it.
I just had a couple of questions maybe. Sure. One is, were you able to replicate this with other hub and spokes? Because this is, I mean, relatively, a fantastic transaction, but about 3-4 crores. One is, were you able to sort of replicate this in other parts? Like, could you do this in sort of 10 cities or 10 other hubs? How did that work?
So this entity is now expanding in 5 states, in 40 centers, over and above our 12 that we support.
With the same structure?
Not with the same structure. Now entity is much better placed in terms of getting that on their own. Break-even much faster because of the economies of scale. So an intensivist can handle 60 to 80 ICUs at any point of time.
Okay, so economies of scale have come before we have to move on, we're just running a bit short. Have you done any pure play equity structures, which is equity and viability gap, or any structure which is just equity based? Because
we have not.
You've done a lot on the debt side.
Yep.
Have you done anything on equity?
So a lot of equity investors have approached us. Can we mix grants with equity? But donors generally shy away from that because equity investors are meant to generate returns. So they don't want to contribute towards generating returns. But we have been able to bring in a lot of debt providers. Right. Indirectly, we have, it is translating to better returns as far as the equity investor or the is concerned, because the entity can scale up much faster.
Got it. Anything else? Last words before we hand over to Karthik. So ultimately, we believe that where there is a will, there is a way, right? So while regulatory constraints are there, but there have been cases we have been able to use right kind of advice from the legal partners. So as Ramraj was mentioning, there will be a session later on, later this month, how some of these structures can be applied and within the regulatory constraints. So I would request all the donors to look at these kind of structures in a positive way and have a growth mindset, I would say, when it comes to making massive impact. Because this is not only about direct leverage or the impact. If this model can be replicated throughout the country, the future pandemics or any other issues that we'll face can be handled much better. So I'll hand over to back to Ramraj and Pragya. Thanks, Archish. Over to you, Karthik, for your slides. And we have about 10 minutes and then maybe 3-4 minutes of quick sort of final words, and then we can kind of close.
Yeah, thanks a lot, Ramraj. And I'll keep it short and quick. So this is basically an extension of the presentation on primary care, where the larger emphasis was really focused on driving health prevention as well as health promotion. And here it's clearly articulated that there is a lot of evidence that really spending on prevention is really a good value for money. We can see that in the context of mental health, we can see that in the context of substance misuse, and we can see that in the context of non-communicable diseases as well. So here, or in the next series of slides, I'll be speaking briefly about a feasibility and a structuring study that we completed in the context of India, focusing on non-communicable disease and really looking at primary and community care lens. If you could just go to the next slide. This is broadly to demonstrate that most of the investments in the context of healthcare in India have really focused on secondary, tertiary, and quaternary aspects of healthcare, focusing largely on curative services, and therefore there has been very, very disproportionately less focus on preventive spending, despite knowing that there is great value of money. And we spoke about this also through the kind of more proximal factors which can really result So this basically talks about why an innovative results-based financing can be quite critical, and the kind of obstacles that it can really try to address when it comes to scalability of deploying certain kinds of high-impact interventions. So basically, uncertainty on the impact of prevention interventions is one of the reasons why it can make a lot of sense to really focus on innovative financing. And this kind of uncertainty can be there because of three reasons. One is that it is not really possible, or it is too expensive to quantify impact. The second is that operationalization of these kinds of preventive interventions really are quite complicated because they involve really a larger set of actors, and it is quite difficult to get them to collaborate on a shared agenda. And largely uncertainty on cost savings, because it's not quite clear how we can standardize this kind of cost savings that can be yielded if you were to focus on prevention. Second is the lack of resources, right? Because since most of the budget and most of the investments are really catering to curative care, there is really constrained budget available for prevention, as well as uncertainty on the cost of the intervention, and this is partly driven by the fact that there is no standard intervention and there is no standard definition of what is the kind of outcome we are looking at, because it's really multiplied. And in that context, healthcare pays for the intervention only if we are in a position to demonstrate that savings have been generated over a period of time. And the third thing is really with respect to misaligned incentives. As we speak about the three different forms of capital and we talk about the multiplicity of stakeholders who are really coming in, it is very, very critical that upfront, even before we try to do a feasibility or structuring, it's quite important to align on what that outcome is going to be. And therefore, in that context, structuring can really tailor each stakeholder's risk and return profile and really help align with really the kind of incentives that they might be looking at. Moving forward to the next slide. This is basically really categorizing for the kind of challenges and opportunities. What are the kind of results-based financing models? This has been articulated in the previous presentation, so I'm not going to go through it. We'll just dive directly into the case study. So if you could go to the next slide. So here, COIS over the last 3 to 4 years has been focusing in a very, very dedicated way on primary care and really trying to understand what is the potential for innovative financing in the context of preventive health. And some of the structuring and feasibility studies for demonstrative purposes here that we have really undertaken is one on breast cancer, where through a feasibility, we really undertook a comprehensive assessment of what are the critical challenges in the breast cancer treatment pathway, particularly for the more aggressive form of breast cancer, which is basically HER2+, and the kind of challenges involved in really accessing the right kind of chemotherapy. And what we did following the feasibility study is basically try to design a solution and attribute the cost of that solution vis-a-vis the kind of impact that it is going to be generating. This was all at a facility-based level, but here the relevance to primary care is that it is quite critical to actually address screening and early detection through the hub and spoke model, and it sort of reiterates the importance of telemedicine solutions for care coordination, radiology solutions too. So this is like one example. The second example is that we undertook a feasibility study to really improve menstrual health and hygiene amongst rural adolescent girls in India. Through this, it was a very, very interesting exercise because during the feasibility study, we took the time to understand what is impact in the context of improved menstrual health and hygiene. So if you see, there are core attributes like increased dignity, self-esteem, and confidence, reduction in basically absenteeism from schools, institutionalization of toilets in public schools. All of these are really proxy factors, but they are actually quite critical when it comes to improving and promoting effective menstrual health and hygiene. These are two examples, but in the next slide, we do a deeper dive on mental health. Now, I think a lot of us have spoken about COVID. There has been a lot of...
We just have about 3-4 minutes, so I just please request you to focus on 1 or 2 key case studies you may want to cover.
All right. So if you could actually switch to another couple of slides, because here we are talking about the burden of mental health as well as the shortage. So I think the previous slide, please. Earlier slide, sorry. Yeah, I think this is good. So during the feasibility study, we tried to identify how we can really deliver an effective mental health solution. And we profiled a variety of mental health care providers, and we found the Atmiyata intervention to be most effective, in which they are basically training community health volunteers and facilitators on the routine aspects of diagnostic, screening, and referral of common mental health conditions. And this particular program has been quite successful in the context of Gujarat, and we thought that this is a great way to really integrate mental health at the level of primary care. The next slide.
So Karthik, in this slide, just 1 second.
Yeah.
Where is the blending, or what is the nature of the structure?
So if you could allow me to actually go further into the next few slides, maybe I could go directly into that, because the effectiveness of the intervention is quite clear. So I think just back slide one bit. So there are 3 critical attributes to this particular intervention. One is to figure out how they can scale say a pre-existing, pre-effective intervention within the same state. The second one is to really figure out how they can move into a new district and really target a new demographic. So therefore, bear in mind that there are 2 core attributes to that particular implementation. Now, how this really helps construct the blended finance instrument is there in the subsequent slide. So in the next slide, what we see clearly is that we used a pay-for-performance component, in which in one of the segments there is a grant component which really focuses on expansion of the care model into a new district and really help address a different demographic of perinatal women who are experiencing depression. So here there is an upfront grant provided to the organization to really set up their operational infrastructure to actually deliver the service and train the healthcare workers. And subsequently there is a performance-linked grant which is really linked to the kind of effectiveness of their pre-existing intervention and their ability to demonstrate success. So this sort of structure was really critical to actually address the needs of a new demographic which was not previously targeted through that specific intervention. And the next component, if you were to look at it, this is part of the scaling piece, right? The next slide, please. So this was aimed at expansion of the pre-existing solution into a higher risk geography, and this was structured through an impact bond where J&J Foundation was basically a risk investor who would be providing the necessary resources to help implement this particular solution, and then there would be an outcome funder. So this is still a live transaction, so we are still in the process of figuring out who the outcome funder is, but this is broadly the structure, Ramraj. This is where I'll stop.
Thanks, Karthik. I think very useful to sort of figure out and see some of the transactions that you've been working on. I think this has been a very energizing and useful conversation. Lots of interesting points, and I think just for closing remarks, maybe I'd like to, Apoor, if you have any specific points or some high-level thoughts, and then maybe I could just summarize with a couple of points.
Sure, thanks, Ramraj. Just maybe a couple of things to mention. First, I think across the room we heard lots of potential use cases of grants, philanthropic money to really propel the market, right? So let me summarize those. One, I think someone from Social Alpha talked about innovation grants to really support those high risk, potentially high impact models and really building the market for those. I think that's critical, and some of us need to play a role there. Someone talked about combining grants with equity investments for supporting some of the non-revenue generating activities or for ecosystem building activities like behavior change. I think that's a critical piece. Third, obviously, a lot of what Archish also talked about, capacity building of non-profits and health enterprises to be able to deepen their impact, but also to become more bankable, to become more investable as a result. De-risking, obviously, guarantees, other things we heard. And lastly, continuing to work on the enabling environment. How can we work, how can some of us work with the government to work on procurements, to work on, outcome pricing for them, to generate interest from that side, to improve payment capabilities, timely payment capabilities of the government. Amit shared an example of the thing that they're doing in Tanzania. So I think all these different aspects, I just wanted to highlight again to say that, all of us in the room and many more have a role to play. But I think coming together on a platform like this, on multi-stakeholder platforms like the one SAMRIDH is very critical to be able to put all of this effort together in a more coordinated way. And lastly, I'll end with saying that, SAMRIDH to a good extent was a result of the emergency situation that COVID brought us. ACT grants, and I think the amount of amazing work they've done was a result of what COVID brought us. So we USAID put almost $30 million into SAMRIDH, which is why we are also starting to, and now we are starting to see success of what grants, if used flexibly, can do to scale the sector up. So I think we need to, now that hopefully COVID is over to large extent, but how do we keep that momentum going and doing more and more similar platform, multi-stakeholder approaches to systematically do some of this. So I'll stop there.
Yeah. Thanks, Apoorv. So I mean, just some high-level last points from my side. I think, 2-3 thoughts come to my mind. One is that we need a concerted, ongoing conversation with regulators and government on this, because on one side, I think it's important for us to continue to showcase transactions. I think even as we spoke, Shama spoke about some transactions, Archish has spoken, Karthik actually had 14, 15 slides. We allowed him to present only 4 or 5 given the paucity of time. There are others who are doing other transactions, so I think just for, if I may loosely put, getting the word out that there is lots happening. This is not some small little thing which happens once in 6-7 months. That's the general impression that people had and have, and that's the impression even I had before I kind of started looking at it. Everyone may not call it blended finance. They may call it something else. It doesn't really matter what people call it. I think to me, one big point is really socialization and ongoing information on what is happening, I think is very valuable. We have a publication called the Market Pulse where we cover deals on equity side and impact, which we publish every month. And we have a click-through rate of about 75-80% of people to whom we send it, and we send it out to almost 7,000-8,000 people who are in the impact, but we still get almost 80% of the people opening it just to see what deals happened. Which just showcases that people are interested. Whether they participate or not is a secondary question. But I think just creating that, I think, is one. Second is just really working and trying to engage with the government, particularly on trying to find structural solutions to some of these issues. A CSR coming in may be a small fix, in terms of the, carry forward from 1 year. But if we can do something on the social venture fund or some of these others, I think that is also something which is going to be valuable. And I think the third point is something that Amit mentioned, which is important, is that we also need to keep working with the NGOs and with the not-for-profits in seeing how we can engage them to see the value of this, so that you can bring more transactions, there's more action, more investment bankers, many more players. Because as we all know, a lot of this is a little bit of herd mentality, is a human nature. If you see 30-40 people doing it, it naturally looks more amenable compared to 5 or 6 people doing it. And I think IIC wants to kind of play that role of bringing all of this together intelligently, not as a domain expert, but as somebody who just has a broader flavor of the market and represents a wider range of investors, foundations, and other people interested in this area. So I think this has been a fantastic conversation. Unfortunately, we did have some technical issues, and it's really, we feel very sorry for some of the people online because of bandwidth issues. We weren't able to really get some of the people, on the way we would have liked. But I think this has been a great conversation. I think lots of interesting points from everyone. We will follow this up with a variety of follow-on conversations, one across sectors, second, different kinds of transactions, and definitely my pet project over the next few months is really to start a publication which is just covering deal flow or potential deal flow. We already have a pipeline of at least 1.5 years of past deal flow, which people may not even be knowing, whereas we've now collected that data for the last 3 to 4 years of all the blended finance transactions that have happened in the country. So, start kind of showcasing those in some fashion, and in parallel start some work with the regulators, particularly in the ambit of the social stock exchange. How can we get some of these? I think those are the 3-4 priorities that I'm taking away from an IIC for this particular kind of conversation. Once again, thank you everyone for your patience and your tolerance for some of the challenges.